Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation. Ann M. Larson, Rachel B. Isaka, David M. Hockenberry. 36 Transplantation of a solid organ is an immunologic mirror of the transplantation of allogeneic hematopoietic cells. Thus solid organs can be rejected by the patient in whom they are placed, whereas allogeneic hematopoietic cells can damage or reject the organs of their recipient. There are similarities in the intestinal and hepatic complications of these transplant procedures, particularly regarding infections and the side effects of immunosuppressive drugs. However, there are extreme differences in the patient populations being transplanted, in the preparation for transplant, and in the degree and length of immune suppression. For this reason, this chapter presents separate problem-oriented approaches to the complications of solid organ and hematopoietic cell transplantation, HCT. Complications of solid organ transplantation. GI complaints after solid organ transplant, SOT, are reported in 20% to 35% of recipients, with a frequency as high as 60% reported in India. Most of the problems relate to opportunistic infections, graft dysfunction, adverse effects of medications, or malignancy. Table 36.1.1-3 Infectious complications remain a major source of morbidity and mortality, particularly within the first 6 months after SOT. 4 However, infection following the first 6 months occurs in up to 16% of SOT recipients. 5 During the first month following SOT, infections include those present prior to transplant, e.g., urinary tract infection, those related to technical complications of the procedure itself, e.g., biliary sepsis, or those transmitted with the allograft. Opportunistic viral, fungal, and parasitic infections are more likely to develop after the first month, with herpes virus infections being the most common. Fig 36.1.4 Universal prophylaxis. Prophylactic antimicrobials, antivirals, and antifungals may reduce the occurrence of these infections. 6 There are several non-infectious complications that can mimic infection, see Table 36.1. CMV is a ubiquitous viral infection, with rates of infection ranging from about half of the adults in the US to over 95% across the globe. 7,8 CMV infection is the predominant viral pathogen occurring within the first year after SOT. Without antiviral prophylaxis, 40% to 60% of seropositive recipients will develop viremia. 9 It can lead to significant morbidity, including allograft rejection and reduced graft survival and mortality. 10-13 Several factors predispose to the development of CMV infection. 10,11 1. Increased immunosuppression, such as anti-lymphocyte antibody in addition to conventional immunosuppression or high-dose maintenance mycophenolate mofetil, MMF, therapy. 4. 2. CMV donor and recipient mismatch. 10-11,14, and 3. Allograft rejection or co-infection with immunomodulating viruses, i.e., human herpes virus HHV6, HHV7, bacteria, or fungi. 4,15 The peak incidence of CMV infection is generally 4 to 6 months after transplantation, once antiviral prophylaxis has been discontinued. Presentations include asymptomatic viremia, CMV syndrome, fevers, malaise, leukopenia, neutropenia, atypical lymphocytosis, elevated liver aminotransferases, and tissue-invasive disease, e.g., GI and hepatobiliary infection, pneumonitis, retinitis. See Fig 36.1.7, 16 Between 70% and 80% of cases of organ-invasive disease in SOT recipients are secondary to GI CMV. 17,18 Active disease can be identified in several ways, including quantitative CMV DNA testing, antigenemia, culture, histopathology, and immunologic assays, which reflect cellular immune response to CMV. 16,19 However, in the setting of end-organ disease, virus may not be detectable in the bloodstream, and CMV must be recovered from intestinal or liver biopsy tissue. 20 The two main methods of disease prevention are post-transplant universal antiviral prophylaxis or preemptive therapy, treating if CMV viremia develops. 21,22 Both strategies are effective in minimizing the incidence of CMV associated Disease. 23,24 Ganciclovir, valacyclovir, or valganciclovir significantly reduces the incidence of CMV disease in transplant recipients. The drug used depends on the organ transplanted. Valganciclovir is not FDA approved in the US for use in the setting of liver transplantation, however, because there was a higher rate of tissue-invasive disease seen in clinical trials. Ganciclovir-resistant CMV has been reported and is an emerging problem in management of CMV disease. 25 The herpes simplex viruses, HSV1/HHV1 and HSV2/HHV2, and varicella-zoster virus, VZV/HHV3, are the next most commonly seen viral infections and characteristically represent reactivation of latent virus within the recipient. 25-27 If antiviral prophylaxis is not used, manifestations of HSV or VZV infection can develop in up to 70% of transplant recipients. 26 HSV has tropism for squamous epithelium, nose, mouth, esophagus, genital, but can involve the intestine, lungs, and liver if patients are not receiving prophylactic antiviral therapy. See Fig 36.1b. Primary HSV infection is uncommon but is generally more severe. 36 Table 36.1 Causes of intestinal and hepatobiliary disorders in solid organ transplantation recipients. Esophageal symptoms: nausea, vomiting, anorexia, abdominal pain, GI bleeding, diarrhea, malignancy. Hepatobiliary disorders: infections, Candida albicans, other fungal species, CMV, HSV, VZV, Mycobacterium tuberculosis, parasites, CMV, HSV, H-pyrrolated ulcers, VZV, Giardia lamblia, cryptosporidiosis, norovirus, rotavirus, EBV, PTLD, CMV, Clostridium difficile, H-pyrrolated ulcers, perforation with abscess, peritonitis, acute cholecystitis, viral pancreatitis, VZV, fungal infection, CMV, fungal infection, Candida, molds, H-pyrrolated ulcers, EBVTLD, C. difficile, HSV, esophagitis, CMV, other viruses, C. difficile, parasites, EBV, PTLD, enteric bacterial pathogens, EBV, PTLD, malt lymphoma, preluded, Kaposi sarcoma, sepsis-related cholestasis, cholangitis lenta, herpes viruses, CMV, HSV, VZV, EBV, HBV, HCV, abscess, fungal, bacterial, non-infectious causes, acid reflux plus or minus peptic stricture, pill, esophagitis, thoracostomy tube, medications, obstruction, uremia, dialysis, pancreatitis, hepatitis, cholecystitis, gastroparesis, GVHD, intestinal obstruction, pseudo-obstruction, narcotic bowel syndrome, immunosuppressive drugs, diverticulitis, ischemic colitis, appendicitis, acute pancreatitis, acute GVHD, intestinal motility disorder, intestinal transplant, biliary leak. LT, NSAID, gastroduodenal ulcers, peptic esophagitis, diverticulosis, especially KT, ischemic colitis, especially KT, biliary or Roux-en-Y, anastomotic bleeding, LT, liver biopsy, hemophilia caused by liver biopsy, variceal bleeding, acute GVHD, promodality drugs, immunosuppressive drugs, sorbitol colitis, ischemic colitis, Mg++ salts, antibiotic-associated diarrhea, lymphoma, skin cancer, colon cancer, recurrent HCC, lung cancer, drug toxicity, vascular injury, LT, nodular, regenerative hyperplasia, biliary tract disease, recurrent hepatocellular carcinoma. Conditions that are described in the literature but rarely seen are in parentheses. GVHD, graft versus host disease, KT, kidney transplant, MALT, mucosa-associated lymphoid tissue, MMF, mycophenolate mofetil, PTLD, post-transplant lymphoproliferative disorder, VZV, varicella-zoster virus. 512 Part 4 Topics involving multiple organs and prolonged in the sought recipient. HSV reactivation is common and often asymptomatic. Symptomatic lesions are similar to those seen in primary infection. Rarely, disseminated HSV can occur, presenting with fever, leukopenia, and hepatitis. 26 Primary VZV infection may also lead to end organ damage. Fortunately, Few adult SOT recipients are susceptible because only 2% to 4% of adults are seronegative for VZV.28. Reactivated disease most often presents as localized shingles, although severe disseminated disease is possible. 28 Up to 20% of SOT recipients will develop symptomatic infection. 25 Lung recipients have the greatest risk, followed by heart, kidney, and liver recipients. 28 30 Prophylaxis with acyclovir, valacyclovir, valganciclovir, or famciclovir reduces recurrence of HSV and VZV following SOT. 31 There are reports of development of HSV antiviral drug resistance in up to 11% of immunocompromised hosts, but little data in the SOT setting. 25 Infections caused by EBV and other human herpes viruses, HHV6, -7, and -8, are less common. As with the other herpes viruses, EBV infection can be either primary or secondary. Clinical disease ranges from asymptomatic viremia to symptomatic disease, including infectious mononucleosis and post-transplant lymphoproliferative disorder, PTLD. 32 Primary infection is often symptomatic and associated with more significant disease. 33 The incidence of EBV-associated PTLD varies, 0.6% to 16%, depending on the organ transplanted and whether the recipient is an adult or a child. 34 PTLD continues to be a problem for SOT recipients who require continued high-level immune suppression. Both B and T cell lymphomas can be seen, Fig. 36.2. HHV6 causes clinical disease in fewer than 1% to 2% of SOT recipients. 25 35 37 Primary infections are rare, and reactivation leads predominantly to subclinical, short-lived infection. It has been reported to cause GI disease. 38 Conclusive evidence of HHV7 as a pathogen is lacking. 25 39 Both HHV6 and -7 predispose the SOT recipient to other opportunistic infections. The role of antiviral prophylaxis in this setting has not been proven and prophylaxis is currently not recommended. 25 HHV8 is oncogenic and can lead to Kaposi sarcoma, Castleman disease, and primary effusion lymphomas, a form of non-Hodgkin lymphoma. HHV8 may also cause a syndrome of fever, bone marrow suppression, and multi-organ failure. 38 Fungal infections usually develop after the first month post-transplant, particularly among those who have discontinued antifungal prophylaxis. The incidence of fungal infection in SOT recipients is estimated to be less than 5%. 40,41 The most common fungi are Candidal species, Candida albicans, Candida tropicalis, but molds such as Aspergillus and zygomycetes are increasing in incidence. 42,43 Beyond the first 6 months following SOT, opportunistic fungal infections occur less frequently, but recipients remain at risk for community-acquired infections. Less common infections: histoplasmosis 1%, coccidioides 1.5% to 8.7%, nocardia, pneumocystis, toxoplasma, and strongyloides, also may occur after the first month. 38,44-46 Kidney and kidney/pancreas transplantation. GI complications are among the most prevalent complications of kidney transplant, KT, seen in up to 50% of patients, and correlate with patient long-term survival. 47-49 It has been reported that KT patients who experience GERD or dyspepsia have an increased risk of graft loss and death, the mechanism of which is unclear. 50 Graft pancreatitis and graft duodenitis generally occur early after kidney/pancreas transplant, KPT, and may lead to intra-abdominal infection. 51,52 The frequency of HCV or HBV/BCDA. Fig. 36.1 Endoscopic photographs of intestinal infections following a solid organ transplant. A. Distal esophageal ulcerations caused by cytomegalovirus, CMV. B. Duodenal ulceration caused by HSV, with a deep, irregular ulcer surrounded by edematous mucosa. C. Colon mucosa in CMV infection, showing focal ulceration, arrow, and pale ulceration and intramucosal hemorrhage in the surrounding mucosa. D. Colonic mucosa in CMV infection with diffuse mucosal friability and ulceration. AB Fig 36.2 computed tomographic findings in lymphoproliferative disease following a solid organ transplant. A retroperitoneal mass, arrows, following a liver transplant, caused by an EBV-positive B-cell lymphoma. B. Distal small intestinal mass, arrows, following a renal transplant, caused by a T-cell lymphoma. The mass was causing intestinal obstruction, with dilated loops of small intestine seen proximal to the mass. Chapter 36 Gastrointestinal and Hepatic Complications of Solid Organ and Hematopoietic Cell Transplantation 513-36 Infection ranges from 5% to 66% of KT and KPT recipients, depending on country of origin. 53,54 The effect of HCV on patient and graft outcomes has been controversial. 55 Many have shown outcomes to be inferior in patients who are chronically infected with either HCV or HBV. 56-59 Cirrhotic patients who undergo KT have traditionally shown a significantly worse 10-year survival compared to non-cirrhotics, with HCV cirrhotics faring worse than HBV cirrhotics. The appropriate use of combined kidney-liver transplantation in this setting remains debated. Both HBV and HCV antiviral therapies have significantly improved the clinical outcome of the KT and KPT recipient. 60 Many serious infections reported in KT recipients are now less common because of more intense surveillance, anti-infective prophylaxis, and preemptive treatment of viral and fungal infection. However, if untreatable life-threatening infection should develop, immunosuppressive drugs can be discontinued, and the patient must be maintained on dialysis, if necessary. This option is unavailable to recipients of other organs. CMV infection is reported in up to 100% of patients after KT or KPT transplant, with a significant portion developing symptomatic disease. 61-63 GI CMV infection is seen in up to about 50% of KT and KPT recipients, with pancreas recipients at greater risk owing to higher levels of immunosuppression. 17,54,64 Clostridium difficile infection is reported in about 3.5% of adults following KT and 15.5% in KPT. 65 About 4% develop intestinal fungal infections, most often with Candidal species. And parasitic infections must also be considered, Enterocytozoan bunazi, Strongyloides stercoralis. 66 HSV infection post-KT is generally asymptomatic and self-limited, but may present as stomatitis, mononucleosis, hepatitis, or pneumonia. 67 Cholecystitis is seen in KT recipients, and the incidence is higher among diabetic patients. 68 Historically, GI hemorrhage developed in up to 20% of KT recipients. Although the incidence has decreased to about 5%, GI bleeding remains a significant cause of morbidity and mortality. 69,70 Surgical outcomes have improved from those seen in the past. 71,72 Many KT recipients with gastroduodenal ulcers will have no past history of gastroduodenal disease. Up to 40% will be asymptomatic, approximately 50% will have complaints of dyspepsia, and 30% to 40% are colonized with HP. 66,73,74 Discovery of ulcer disease requires a high index of suspicion in this patient population. With decreased use of glucocorticoids and use of PPIs or H2RAS, ulcer formation and hemorrhage have become less common. 3 Many GI symptoms, e.g., diarrhea, nausea, vomiting, abdominal pain, were related to the use of MMF, which has been largely abandoned in favor of enteric-coated mycophenolic acid, with fewer gut side effects. 75,76 An acute abdomen may be seen in up to 10% of patients and can be related to pancreatitis, cholecystitis, perforated ulcer, diverticulitis, appendicitis, and intestinal obstruction. 77 Renal recipients are at particular risk for the development of intestinal ischemia compared with other SOT recipients. The incidence is low, 5%, however, and the etiology is multifactorial. 78 Recipients with polycystic kidney disease more often develop intestinal ischemia and obstruction. 79 This group also has a higher percentage of patients with diverticular disease and complications. 66,79,80 Intestinal ischemia in this setting carries a high mortality. Ischemia should be considered in KT recipients with abdominal pain, particularly older patients, greater than 40 years of age, who have received a cadaveric kidney. 78 Liver transplantation. As also discussed in Chapter 97, GI complications unique to orthotopic liver transplantation, ALT, are generally related to the surgery itself and include intra-abdominal hemorrhage, hepatic arterial stenosis or thrombosis, biliary tract dysfunction, bowel perforation, bowel obstruction, and GI bleeding. 81. Hepatic artery thrombosis develops in 5% to 9% of adult recipients and presents with a spectrum of consequences, ranging from mildly elevated liver enzymes with or without fever to acute hepatic failure necessitating urgent retransplantation. 82 Moreover, the biliary tree receives its entire blood supply from the hepatic artery following ALT, and loss of this arterial flow results in bile duct necrosis and leakage, with development of intrahepatic bilomas and abscesses, Fig 36.3a and b. 83,84 Gradual loss of hepatic arterial flow can also result in hepatic ductopenia, which is indistinguishable from ductopenic rejection. Portal vein thrombosis has been reported in up to 12% of transplants and can lead to hepatic ischemia and severe hepatic dysfunction if it occurs early in the post-transplant course. Later, signs of portal hypertension develop. Rarely, hepatic vein thrombosis and inferior vena cava thrombosis or stenosis can create a Budd-Chiari-like syndrome. Biliary complications are the most common cause of morbidity after ALT, ranging from 5% to 30%. 85 Bile leakage, with bilomas and stricture formation, generally at the anastomotic site, are the most common of the biliary abnormalities. See Fig 36.3a and b. 85,86 Anastomotic strictures account for up to 80% of stricturing disease. They generally present within 2 to 6 months post-ALT but can occur in the newly transplanted patient as well. Strictures and leaks in patients with duct-to-duct anastomosis are often amenable to endoscopic therapy, whereas those with cholecystocele may require percutaneous or surgical correction. Non-anastomotic strictures raise the concern of hepatic artery insufficiency. 87 Biliary casts may develop ABC. Fig 36.3 Hepatobiliary imaging following a liver transplant. A. Endoscopic retrograde cholangiogram showing an ischemic stricture, arrow, of the bile duct following the transplant. B. Endoscopic retrograde cholangiogram showing a bile leak, arrowhead, at the biliary anastomosis, arrow, following transplant. C. Magnetic resonance cholangiogram of the intrahepatic biliary system showing recurrent sclerosing cholangitis in the liver graft. The arrow points to a stricture, with upstream biliary dilatation. 514 Part 4 Topics involving multiple organs in up to 18% of recipients and generally occur within the first year post-ALT. 39,88 Clinical factors associated with development of biliary casts include hepatic ischemia and biliary strictures. Endoscopic and percutaneous therapy are successful in up to 70%, but surgical intervention may be required, and mortality has been reported at 10% to 30%. 39,89 Infection is the most common cause of morbidity and mortality post-ALT, seen in up to 75% of recipients. 90 Immediately following transplant, hospital-acquired infections and wound infections can be seen. GI CMV infection is reported in up to 40% of liver recipients. 17 CMV hepatitis is the most common manifestation of CMV post-ALT and is more severe in ALT recipients than in recipients of other organs. 91, 92 Patients often have elevations in serum aminotransferases, which can be confused with rejection, therefore, liver biopsy is essential for diagnosis. The diagnosis can usually be confirmed by the detection of CMV DNA in the bloodstream. 93 Asymptomatic low-level CMV viremia usually does not require antiviral therapy. 94 ALT recipients more often develop invasive fungal infections than other SOT recipients, with a high mortality. In the absence of antifungal prophylaxis, invasive infections occur in up to 42% of recipients, and Candida species account for the majority. 95,96 A serum galactomannan assay is useful for detecting mold infections, particularly invasive aspergillosis. 97,98 invasive fungi are becoming increasingly resistant to antifungal therapy. Acute pancreatitis is rare, but has been reported in up to 5.7% of all recipients and carries a high mortality, up to 64%. 39,99 There is a risk for recurrence of the underlying liver disease following ALT, including HCV, HBV, autoimmune hepatitis, NASH, PBC, and PSC. See Fig 36.3c. Point 100-103 Recurrence of HCV in the liver allograft is nearly universal. See chapters 80 and 97. Historically, this led to significant increased graft loss. 104-107 With the development of multiple highly effective direct-acting antiviral drugs, however, this is no longer an issue. HBV recurrence may be prevented with the use of hepatitis B immune globulin, HBIG, and antiviral medications. PBC recurs in about 26% of patients post-ALT, see Chapter 97. 101 Heart, lung, and heart-lung transplantation. Up to half of heart, HT, lung, LT, and heart-lung transplantation, HLT, recipients experience GI complications, with up to 20% requiring surgery. 108,109 The most common complications include diarrhea, GERD, dyspepsia, nausea and vomiting, abdominal pain, acute abdomen, pancreatitis, herpes virus infections, especially CMV, cholelithiasis, ulcers, and hepatobiliary disease. 108-110 Biliary disorders are reported in up to 40% of patients, and they carry a high mortality with surgical intervention. 111 GERD and gastroparesis are particularly problematic after LT or HLT and may be related to medications and vagal nerve injury during the operation. 109,112-115 Symptomatic gastroparesis has been described in 25% of LT recipients and up to 80% of HLT recipients. 116-118 The course is often waxing and waning, suggesting a neuropathic, infectious, CMV, or medication-induced etiology. 117,119 Recipients with GERD and/or gastroparesis are at particular risk for the development of bronchiolitis obliterans syndrome, which significantly threatens the longevity of LT recipients. 115-117 PPIs can be used to help control reflux. However, if reflux disease is unremitting, laparoscopic fundoplication may be successful. 120-122 LT recipients may develop giant gastric ulcers, greater than 3 cm in diameter, which occur despite routine use of acid suppression. These ulcers carry significant morbidity and mortality, and are more often associated with bilateral LT, use of high-dose NSAIDs after transplant, acute rejection requiring high-dose glucocorticoids, and cyclosporin immunosuppression. 123 For this reason, some authors believe NSAIDs should not be used in the post-transplant setting. Recipients of LT and HT more often develop CMV infection, 15% to 25%, than other SOT recipients. Generally, CMV infection presents as pneumonitis, but GI CMV infection remains a major cause of morbidity. See Fig 36.1. 14 LT and HLT recipients have the highest incidence of fungal infection in the SOT setting, and non-candidal species predominate. 124,125 Patients undergoing LT for CF experience a unique set of GI complications. 126 Pancreatic insufficiency, a marker for severe CF, is common. CF-induced secondary biliary cirrhosis can complicate absorption of immunosuppressive medications such as cyclosporin. If severe liver disease is detected prior to LT, lung liver transplant can be considered. Distal intestinal obstruction syndrome occurs in up to 10% and is similar to the incidence in CF in the non-transplant setting. 127 CF patients may also experience cholecystitis, PUD, and GERD. 128 Primary HCV infection following HT has led to significantly increased 1- and 3-year mortality. With newer antiviral medications now available for hepatitis C virus infection, this is likely to change over time. Acquisition of HBV following HT does not appear to affect survival, at least up to 5 years. 129,130 Intestinal transplantation. Most complications are related to underlying diseases, graft rejection, intestinal ischemia, and anastomotic leaks. Bacterial and fungal infections are common, often associated with mucosal disruption following surgery, but a source may not be identifiable. 2 types of malignancy related to intense immune suppression have been reported: EBV lymphoproliferative disease, LPD, and de novo cancers of non-lymphomatous origin. 131,132 Surveillance for EBV DNA and preemptive treatment by reducing immunosuppression or using rituximab reduces the frequency of LPD. Altered intestinal motility and anorexia have been reported. SOT graft versus host disease, GVHD, is seen in up to 9% of intestinal transplant recipients. Problem-oriented approach to diagnosis in solid organ transplantation recipients. Upper intestinal symptoms and signs. The approach to SOT patients with esophageal or gastric symptoms is influenced by a high frequency of nonspecific symptoms as harbingers of serious infection, e.g., CMV infection presenting as nausea and vomiting, and by the rapidity with which disease can progress. GERD is the most common cause of heartburn and mid-chest pain, particularly following LT, but viral and fungal esophagitis may underlie these symptoms, particularly after antimicrobial prophylaxis has been discontinued. Candidal esophagitis is seen with high frequency in those with diabetes. Other risk factors include use of broad-spectrum antibiotics, high-dose immunosuppression, and the presence of a Roux-en-Y anastomosis in ALT recipients. Severe necrotizing fungal esophagitis can lead to perforation, which can have a fatal outcome in up to 1/3 of cases. Odynophagia, dysphagia, or hematemesis should lead to consideration of an esophageal infection. Herpes viruses, CMV, HSV, and fungal species, Candida, are responsible for the largest proportion, but unusual organisms can be seen. 133 Dysphagia secondary to pill esophagitis may develop in SOT recipients who are ingesting antibiotics, antivirals, potassium chloride, bisphosphonates, NSAIDs, and iron pills. Esophageal strictures following severe esophageal infection have been reported and may present long after eradication of the organism. Anorexia, nausea, and/or vomiting are common following SOT, particularly early in the post-transplant course. 48,108,109 These symptoms are often related to herpes virus infections or medications, including immunosuppressive drugs, thus endoscopic evaluation is necessary for diagnosis in most patients. Tacrolimus is a macrolide lactone that can cause nausea. Abdominal. Chapter 36 Gastrointestinal and Hepatic Complications of Solid Organ and Hematopoietic Cell Transplantation. 515 36 Pain, and diarrhea, often leading to anorexia, food aversion, and weight loss. These side effects are dose-dependent and can be managed with dose reduction or, more rarely, drug discontinuation. Sirolimus, Ropamune, a newer macrolide immunosuppressant, has a GI side effect profile similar to tacrolimus. MMF is an inhibitor of nucleic acid synthesis with well-described GI side effects of nausea, vomiting, and diarrhea, often requiring dosing modifications. The formulation of mycophenolic acid delayed-release tablets has significantly fewer GI side effects, with similar therapeutic efficacy. 75, 76, 134 Less common causes of anorexia and nausea include pancreatitis, cholecystitis, or cystitis. Rarely following SOT, 1%, and within the first 2 to 6 weeks after transplantation, GVHD presents with fever, rash, and GI symptoms, particularly nausea, vomiting, and diarrhea. 135, 136 Endoscopic evaluation with biopsy is essential if GVHD is suspected and skin lesions are absent, recognizing that other conditions such as viral infections and drug reactions can have a GVHD-like histologic pattern. 137 Symptomatic gastroparesis is frequently seen in the setting of LT but is less often reported in the setting of other SOT. 117 CMV and VZV may rarely involve intestinal neural plexuses, leading to intestinal dilation or gastroparesis. HP infection may be associated with symptomatic dyspepsia, gastritis, and gastroduodenal ulceration, but there is no relationship between the use or degree of immunosuppression and HP colonization. Its incidence is similar to that seen in the non-transplant setting. 2 HP infection is common in dialysis and KT patients. 66 Diarrhea and constipation, colonic and small bowel complications, diverticulitis, ischemic colitis, malignancy, and infections, have been reported following all types of SOT. Early in the post-transplant setting, infections predominate, and diarrhea may be accompanied by fever, 37%, abdominal pain, 46%, nausea, 32%, and vomiting, 22%. 138,139 The microbes predominantly responsible are CMV and C. difficile, but the literature describes a wide range of organisms in SOT recipients, particularly when they are cared for in infection-endemic areas, e.g., adenovirus, norovirus, rotavirus, coxsackie bacterial enteric pathogens, enterohemorrhagic Escherichia coli, Yersinia enterocolitica, Giardia lamblia, Candida species, Cryptosporidia, Microsporidia, E. bunesi, Iospora belli, S. stercoralis. 139,140 Bacterial intestinal tract infections occur more often if the patient also has concomitant systemic CMV. 65 Diagnosis can be made by examination of stool specimens in nearly all cases. The exceptions are CMV, certain parasites, and EBV-associated lymphoproliferative disorders, EBV-LPD. Small intestinal involvement with CMV often causes profuse watery diarrhea with protein-losing enteropathy, particularly if the diagnosis is delayed. Colonic involvement may appear as an inflammatory colitis resulting in bloody diarrhea and is often associated with fever, abdominal distension, and pain. 141,142 Diagnosis of colonic CMV requires mucosal biopsy, particularly if blood specimens are negative for CMV DNA or antigen. C. difficile occurs in 2% to 30% of hospitalized SOT recipients, a greater incidence than in the general hospitalized population, 1% to 2%. 143 C. difficile infection may present with a more severe course post-SOT. Patients with fulminant colitis, intestinal obstruction, abscess, and toxic megacolon require prompt surgical intervention to prevent perforation and peritonitis. 139,140 Signs of colitis may be subtle and is because of concomitant immune suppression. Treatment is discussed in Chapter 112. Recurrence may develop in up to 20% of cases. 144 The use of certain probiotics, e.g., Saccharomyces boulardii, in SOT recipients remains controversial because there have been reports of yeast dissemination and infection in the immunocompromised host. 145,146 However, it appears that the use of bacterial probiotics may help prevent infection. 147 And transplantation of normal colonic bacterial flora can be useful in treating recurrent C. difficile colitis. See Chapter 112. Intestinal fungal infections can be seen in up to 25% of SOT recipients. In the absence of prophylaxis, intestinal fungal overgrowth and diarrhea can result from antibiotic use or intestinal dysmotility. Common parasitic infections must also be considered in an immunocompromised host, particularly in areas of high endemicity. The protozoa and metazoan parasites are a much less frequent cause of acute diarrhea post-SOT but must be considered. Microsporida, E. bunesi, is a more rarely reported cause of chronic diarrhea, perhaps reflecting the fact that it is often not sought out in the post-SOT setting. 148 Clinically, patients with this infection experience fatigue, intermittent diarrhea, and weight loss. There are no clearly effective therapies for E. bunesi. Symptoms of colitis or toxic megacolon are most often associated with infection, but in up to 20% of cases, no clear etiology can be found. 139,149 Early recognition, diagnosis, and treatment of colitis can decrease disease-associated mortality. There are reports of donor-transmitted infections with S. stercoralis, which carries a high mortality rate. This pathogen should be considered when donors hail from endemic regions. Eosinophilic colitis with diarrhea has been reported with the use of both tacrolimus and cyclosporin. Histologically, this is characterized by eosinophilic colonic infiltrates and peripheral eosinophilia, Elevated serum immunoglobulin, IgE, may be present in some patients. Colonoscopy is generally only needed if non-invasive testing for infectious causes is unrevealing. Lower GI tract GVHD must be considered in those patients in whom an infectious etiology cannot be found. Drug-related diarrhea is seen in up to 2/3 of SOT patients, most commonly with tacrolimus or sirolimus. 139,150,151 mmF causes watery diarrhea in up to 30% of patients, and may require dose reduction or discontinuation. The mechanism of MMF-induced diarrhea is unclear. It is dose-dependent and may be related inhibition of de novo purine synthesis within the enterocyte. Histology shows focal inflammatory lesions similar to GVHD with loss of villus architecture of the duodenum. 152 The use of enteric-coated mycophenolic acid has decreased this side effect. Anti-thymocyte globulin, ATG, and anti-T-cell antibody, OKT3, therapies are both associated with diarrhea, which predictably lasts for 3 to 4 days and resolves spontaneously. Most cases of immunosuppressant-induced diarrhea can be managed with dose manipulation, but some are so severe that discontinuation of the immunosuppressant is required. Diarrhea can also be caused by magnesium-containing preparations prescribed to correct renal magnesium wasting and by antibiotics prescribed either prophylactically or therapeutically. Non-infectious diarrhea has been reported to increase the risk of graft loss and mortality. 150 Constipation is seen in less mobile SOT recipients who are receiving certain medications, e.g., narcotics, calcium and aluminum-containing antacids, anticholinergics. The constipation is generally responsive to increased patient mobility, decreased use of narcotics, use of methylnaltrexone in those receiving narcotics. 153 and therapy with polyethylene glycol laxatives and senna. Abdominal pain. Abdominal complications are common following SOT, affecting up to 30% of patients. 153 Symptoms may be mild despite the presence of life-threatening complications. All patients with abdominal pain should be aggressively evaluated, with attention as to whether the patient requires urgent surgery or a specific medical treatment. Most recipients with abdominal pain will not need surgery. The intra-abdominal conditions presenting with pain that require urgent surgery are abscess, perforation, severe colitis, appendicitis, intestinal obstruction, intestinal ischemia, and acute cholecystitis. These disorders may appear in the early post-transplant period. Immunosuppression may mask symptoms, and 516 Part 4 topics involving multiple organs suppress the host response, leading to a delay in diagnosis and an increase in mortality. Most transplant patients with acute appendicitis will have typical right lower quadrant pain, although complications are more frequent. 154 Overall, intestinal perforation occurs in fewer than 5% of SOT recipients, although the incidence may be slightly higher in the setting of lung transplant. 47,155 Perforation may occur spontaneously without clear etiology, but it is associated with colon diverticula in up to 2/3 of cases, particularly kidney recipients, and ischemia in 15%. Perforation, especially diverticular, carries a high mortality. 78,142 Risk factors for the development of colonic perforation include diverticular disease, immunosuppression, particularly glucocorticoids, CMV infection, fungal infections, e.g., mucormycosis, unrecognized lymphoma, EBV-LPD, colon cancer, and ischemia. 2,142 Abdominal X-rays and CT can confirm the presence of perforation, but may not reveal its source before surgery. Diverticular perforation is especially common after renal transplant, often leading to abscess formation and fistulization, sometimes without causing severe pain or findings of peritonitis. Pre-transplant colonic screening in patients younger than 50 years does not predict post-transplant colonic perforations. SOT recipients are also at increased risk for the development of cholelithiasis. 156 Factors related to gallstones include cyclosporin, obesity, and CF as an underlying disorder. Abdominal pain is frequently associated with tissue-invasive CMV disease. CMV may also cause focal ulceration, perforation, high-grade stricture, and intestinal obstruction. See Fig. 36.1, while generally producing a diffuse pattern of mucosal edema. The first manifestation of disseminated VZV infection is often severe abdominal pain related to pseudo-obstruction and visceral neuropathy. Early treatment of both CMV and VZV infection results in improved survival. Abdominal pain may also be a manifestation of transplant-related complications that do not usually have a dire outcome. Pain has been reported with oral tacrolimus, sirolimus, and MMF. Abdominal pain secondary to MMF is seen in up to 19% of those receiving it and can significantly limit its use. 157 The etiology of MMF-induced pain been postulated to involve inflammatory ulcers, seen at endoscopy, as well as interference with rapidly dividing intestinal cells, a hypothesis supported by studies showing fewer GI complications with delayed-release mycophenolic acid, compared to MMF. 75,76,134 Narcotic or anticholinergic-induced pseudo-obstruction is common after surgery. Care must be taken to rule out an infectious etiology such as CMV or VZV, both of which can involve the intestinal nerve plexuses. 2 Non-infectious pseudo-obstruction often can be managed conservatively, with nasogastric decompression, vigorous correction of electrolyte imbalance, and withdrawal of opiates. Mu-agonist opioid-related gut symptoms can also be blocked with the use of methylnaltrexone without interfering with central pain relief. 153 Neostigmine can be safely used for treatment of pseudo-obstruction in the transplant setting. 142 Surgical intervention may be required in the setting of massive colon dilation. Acute pancreatitis has been reported in 1% to 2% of renal transplant recipients, up to 6% of LT recipients, and up to 18% of HT recipients. It may have a fatal outcome. 158 Acute pancreatitis is associated with CMV infection, hypercalcemia, cholelithiasis, biliary manipulation, malignancy, recent alcohol ingestion, and medications such as azathioprine, cyclosporin, tacrolimus, and glucocorticoids. Treatment of pancreatitis in the post-transplant setting is identical to that in the non-transplant setting, except for the need to exclude CMV infection and some immunosuppressive medications, see Chapter 58. Pneumatosis intestinalis may be discovered during abdominal imaging after SOT as an incidental finding, but can also be a manifestation of life-threatening intestinal ischemia or infection with a gas-forming organism. 159 Pneumatosis intestinalis can be associated with CMV infection, C. difficile colitis, and sepsis, and can be seen in patients receiving glucocorticoid therapy. Most patients require no specific intervention, and the gas collections resolve spontaneously unless caused by ischemia or an infection with a clostridial organism. 159 Gastrointestinal bleeding. When GI bleeding occurs, it is often secondary to infectious ulcers. Non-infectious causes of hemorrhage include NSAID-induced gastroduodenal ulcers, diverticular bleeding, anastomotic bleeding, and ischemic colitis. The current incidence of gastroduodenal ulcer disease in the transplant population is now about 5%, with perforation rates of less than 1%. 3 Prophylaxis with H2RAS or PPIs decreases the occurrence of ulcer disease in this population. These two therapies are equally effective in KT recipients. 3 Patients infected with HP prior to transplantation are more likely to develop PUD following transplant. 160 In the absence of effective antiviral prophylaxis, viral ulcerations are the most common cause of GI bleeding. HSV-associated esophageal ulcers may present with severe bleeding even in the absence of esophageal symptoms. CMV can lead to ulceration throughout the entire intestinal tract. Whereas CMV esophageal ulcers are usually shallow, see Fig 36.1a, ulcers in the stomach or intestine can be deep, erode into vessels, and lead to severe bleeding. CMV can also cause diffuse colonic inflammation resembling that seen in IBD, see Fig 36.1c and d. VZV and EBV are much less often associated with GI bleeding. Although EBV itself does not cause mucosal ulceration, EBV-associated LPD can form mucosal tumors that can ulcerate and bleed, see Fig 36.2. Massive bleeding has been reported in the setting of invasive fungal infection. 161 Gastrointestinal malignancy PTLD, lymphoid proliferations, or lymphomas associated with EBV infection occur in up to 20% of transplant recipients. 32,162 Although most PTLD is of B-cell origin, T-cell lymphoma has been reported. 163 EBV reactivation generally presents in the early post-transplant setting as a mononucleosis-like syndrome with diffuse adenopathy and fever. Detection of EBV DNA in the bloodstream may allow preemptive therapy, with lower doses of immune suppression or treatment with rituximab. 164 PTLD manifesting later than a year after transplant is more insidious, often presenting with extranodal disease or visceral involvement. GI PTLD can present with diarrhea, intestinal obstruction, see Fig 36.2b, bleeding, or perforation. Mucosa-associated lymphoid tissue, MALT, type lymphomas have also been reported in the post-transplant setting. 165 Fortunately, they often respond to reduction in immunosuppression, antibiotics, if associated with HP, surgery, or chemotherapy, see Chapter 32. The risk of cancer in long-lived transplant recipients is higher than in the general population, particularly for lymphomas, skin cancers, colon and anal cancers, head and neck cancers, and Kaposi sarcoma. 166,167 Patients who underwent ALT for cirrhosis secondary to PSC are at high risk for the development of colonic dysplasia and diffuse colon cancer related to underlying ulcerative colitis. 168 If severe dysplasia is discovered, colectomy can be performed safely as early as 10 to 12 weeks following transplant. Hepatobiliary complications. Drug-induced hepatotoxicity can be problematic after SOT because this diagnosis is often one of exclusion. Azathioprine hepatotoxicity presents as an elevation in serum aminotransferase enzyme levels in up to 10% of recipients. Injury is generally cholestatic with centrilobular hepatocyte damage. A less common presentation is the slow, insidious development of sinusoidal obstruction syndrome, SOS, formerly veno-occlusive disease, which often manifests as portal hypertension, usually regressing following withdrawal of the drug. Azathioprine is used less often. Chapter 36 Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation. 517-36 Now following organ transplant, having been largely replaced by mycophenolic acid. Cyclosporin or tacrolimus-induced cholestasis can occur when their blood levels are high. Sirolimus has been reported to cause dose-dependent elevations in serum aminotransferase levels. Transplant recipients are exposed to numerous other pharmacologic agents that alone, or in combination, can produce cholestasis, fatty liver, hepatitis, or a mixed histologic picture. Bacterial sepsis can have profound effects on liver function, see Chapter 37, with severe cholestasis the most common finding, a syndrome sometimes called cholangitis lenta or hyperbilirubinemia of sepsis. 169 CMV infection may lead to elevations in hepatic enzymes, with either a cholestatic or hepatocellular picture. CMV hepatitis is more frequent and severe in LT recipients compared to recipients of other organs. 91 VZV and HSV infection can lead to hepatitis and fulminant liver failure. 26,67 EBV hepatitis is seen in 2% to 3% after SOT but is generally mild. Primary or recurrent disease with either HCV or HBV can lead to liver disease in the post-transplant setting. These viruses may also be passaged by any solid organ. Fortunately, antiviral therapy for both has improved outcomes significantly. 104 The treatment of HCV in the post-transplant setting has improved greatly with development of direct-acting antivirals, curing up to 98% to 99% of recipients. 170 In fact, at the time of this writing, the success of these medications has led to the consideration of use of HCV viremic donors for HCV-negative recipients. 171,172 Chronic HBV carriers, hepatitis B surface antigen-positive recipients, may develop a flare following transplant, but disease responds well to antiviral agents, see Chapter 79. Vascular injury associated with ALT may lead to liver dysfunction. Nodular regenerative hyperplasia with subsequent portal hypertension and peliosis hepatis have both been reported following renal transplantation. Organ transplant recipients, particularly those with LT, are at high risk for biliary tract disease. Presentation includes acalculous cholecystitis, gallbladder sludge, thickened gallbladder wall, dilated bile ducts, or cholelithiasis. 111 Diseases of gallbladder and biliary necessitating cholecystectomy have a post-transplant incidence of 1% to 6%. Emergent cholecystectomy in the post-transplant setting carries a high mortality, 29%. 111 However, pre-transplant biliary screening and prophylactic cholecystectomy remain controversial. The etiology of biliary tract disease is multifactorial, including obesity, use of TPN, fasting, biliary strictures, and medications. Cyclosporin, excreted in the bile where it may precipitate, has been implicated in an increased incidence of cholelithiasis and cholangitis. 68,173 Some centers recommend that biliary calculi be removed prior to transplantation or immediately upon discovery after transplantation. Patients who have undergone ALT for hepatocellular carcinoma are at risk for recurrence in the graft, particularly if the lesions were multiple or large prior to transplant. PTLD may also involve the liver. Complications of hematopoietic cell transplantation. HCT uses one of three sources of hematopoietic and immune cells: bone marrow, peripheral blood hematopoietic cells, or cord blood. 174 Transplanted cells can be one's own, autologous HCT, from an identical twin, syngeneic HCT, or from another person, allogeneic HCT. Allogeneic cells can come from a sibling who is HLA matched with the recipient, from another family member, from an HLA-matched unrelated donor, or from an HLA-mismatched unrelated donor, as with cord blood donors. HCT differs from SOT in three important ways. 1. The indication for HCT often involves a potentially fatal malignancy, bone marrow failure, aplastic anemia, a congenital immune deficiency, or a genetic hematologic disorder such as thalassemia or sickle cell disease. 2. Preparation for HCT requires either high-dose myeloablative therapy or intense immune suppression, resulting in extreme susceptibility to infection and, with some preparative regimens, damage to the liver, kidneys, lungs, and heart. And 3. Recipients of allogeneic donor cells commonly develop acute and chronic GVHD. HCT patients face combined morbidity from the toxicity of chemotherapy drugs, infections, acute and chronic GVHD, and recurrent malignancy. 174 GI and hepatic complications of HCT have now become far less frequent, and some past problems seen have disappeared. 174,175 Guides to the sometimes arcane HCT terminology and abbreviations can be useful to those unfamiliar with HCT. 176 Evaluation of intestinal and liver disorders before hematopoietic cell transplantation. Ulcers and tumors in the intestinal tract in immunocompromised patients who are candidates for HCT. Mucosal ulcers may have an infectious etiology that requires specific antimicrobial treatment. 177 CMV, Entamoeba histolytica, and C. difficile are infectious causes of colonic ulceration that may mimic IBD. Intestinal ulcerations should be healed before the start of conditioning therapy to avoid major bleeding during post-HCT thrombocytopenia. Patients with ulcerative colitis and Crohn disease have undergone both allogeneic and autologous HCT without complications of bleeding, perforation, or dissemination of unusual microorganisms. 178,179 Long-term resolution of Crohn disease has been observed following myeloablative allogeneic HCT, and autologous HCT has resulted in improvement as well. Monogenic autoimmune syndromes, including many patients with very early onset IBD, can be cured after allogeneic HCT. 180 Any recent history of GI bleeding should prompt both colonoscopy and upper endoscopy before HCT. Endoscopic biopsy may be required for staging some malignant disorders with a predilection for gut involvement, e.g., mantle cell lymphoma, see Chapter 32. Diarrhea. Patients with diarrhea should be investigated for organisms that may cause morbidity after HCT, E. histolytica, S. stercoralis, G. Lamblia, Cryptosporidia, Microsporidia, Clostridia, CMV, Rotavirus, Norovirus, Adenovirus. 181,182 Many, but not all, of these pathogens are included in multiplex molecular panels now available, and specific therapy is available for Clostridia, CMV, Adenovirus, Amoebiasis, Giardiasis, Strongyloidiasis and other helminths, and Microsporidia. 183 Cryptosporidiosis is resistant to therapy in an immunosuppressed patient, but restoration of normal immunity after allogeneic HCT can result in clearance of Cryptosporidia. 184 Typhlitis is a syndrome of cecal edema, mucosal barrier injury, and ulceration in neutropenic patients, often associated with polymicrobial sepsis. Its cause is usually an intestinal clostridial infection, particularly with Clostridium septicum. 185 After treatment and recovery, the risk of post-HCT typhlitis is similar to other patients. Perianal pain near the anal canal in a granulocytopenic patient is due to bacterial infection until proved otherwise. Administration of broad-spectrum antibiotics with anaerobic coverage is adequate treatment in most cases, with surgical incision and drainage reserved for progressive infections. 186 Extensive supralevator and intersphincteric abscesses may be present without being apparent on external examination, but can be diagnosed by CT, MRI, or transperineal sonography. 187 Proctitis and genital ulcers due to HSV and CMV infections may also lead to perianal pain. 188 518 Part 4 Topics involving multiple organs. Fungal liver infections diagnosis depends on liver imaging, high-resolution CT or MRI, in conjunction with fungal biomarkers, galactomannan and glucan assays, PCR, or culture of liver biopsy material. 189 Fungal liver infection should be treated with echinocandins that offer reduced toxicity, fewer drug-drug interactions, and a broader range of coverage than older drugs. 190 A fully engrafted patient can then clear intractable fungal liver abscesses after HCT. Viral hepatitis in allogeneic hematopoietic cell transplant donors. Donors who are viremic with HBV or HCV will likely transmit virus to their recipients. When two equally HLA-matched donors are available, the uninfected donor is preferred. If the most suitable donor has chronic hepatitis B, treating that donor and recipient with entecavir or tenofovir and passive or active immunization of the recipient may prevent passage of virus. 191 HBsAg negative. Anti-HBC positive donors can be used if their serum and peripheral blood mononuclear cells, PBMCs, are HBV DNA negative, with monthly monitoring of serum HBV DNA in recipient after transplant. A donor who is naturally anti-HBC positive may be the preferred donor if the recipient is HBsAg positive or anti-HBC positive, because adoptive transfer of immunity can affect clearance of virus. 192 If a donor is infected by HCV and if time permits, treatment of the donor prior to harvest of donor cells can render them non-viremic and much less likely to transmit infection. 193 New DAA drug combinations are the treatment of choice for this indication. See Chapter 80 and www.hcvguidelines.org. 194 If HCV is transmitted, the acute phase of HCV infection may cause elevated liver enzymes by 2 to 3 months post-HCT after recovery of T-cell function. Increased 1 to 2 year non-relapse-related mortality has been observed in HCV-infected patients than HCV-negative controls, including excess deaths related to bacterial infections. After 10 years, the outcome is no different than in transplant recipients without hepatitis C infection. 195,196 However, fibrosing cholestatic hepatitis C has rarely been described after HCT in patients receiving MMF for immune suppression. 197 Antiviral treatment should be offered to the recipient with chronic hepatitis C. In particular, patients with fibrosing cholestatic hepatitis, decompensated cirrhosis, and HCV-related lymphomas. Preliminary studies suggest antiviral treatment can reduce non-relapse mortality, as well as the longer-term risk for development of cirrhosis and hepatocellular carcinoma. 198 Liver disease in candidates for hematopoietic cell transplantation. The risks faced by patients with fibroinflammatory liver disease include fatal SOS following some myeloablative regimens. 176 Child Pu B or C cirrhosis is a contraindication to most high-dose conditioning regimens because of the risk of developing fatal sinusoidal injury. These patients may also develop fatal sepsis or hepatic decompensation after HCT even if given a reduced intensity conditioning regimen. 199,200 Liver biopsy or transient elastography should be considered if there is a clinical suspicion of cirrhosis or extensive fibrosis resulting from chronic viral infection, alcohol, or NASH. Myeloproliferative neoplasms can present with non-cirrhotic portal hypertension and an increased incidence of early post-transplant hepatotoxicity. 201,202 Patients with Gilbert syndrome exhibit increased non-relapse mortality after conditioning with busulfan, buletin, containing regimens. 203 More recent liver injury caused by chemotherapy or radiation in the months before transplant can also pose risk. Many chemotherapy drugs cause liver dysfunction either directly, cholestatic injury, hepatocyte necrosis, or sinusoidal damage, or indirectly, cholestasis caused by sepsis or endotoxemia, i.e., cholangitis lenta. 204 Although exposure to standard chemotherapy per SE has not been associated with an increased risk of fatal SOS, patients presenting for HCT with persistent jaundice and elevations of aminotransferase enzymes are at risk. 205 Liver injury has been associated with prolonged exposure to antimetabolites such as 6-thioguanine, as well as agents such as imatinib, Gleevec, and newer tyrosine kinase inhibitors. 206 Gemtuzumab ozogamicin, Mylotarg, predisposes patients to SOS after hepatotoxic myeloablative regimens, particularly if the patient is transplanted within 3 months of high-dose gemtuzumab exposure. 207 Gallbladder and bile duct stones. HCT candidates with asymptomatic gallstones, incidentally discovered during CT or US, do not require operative intervention. Patients with symptomatic cholelithiasis or stones in the common duct should be considered for pre-transplant cholecystectomy or an endoscopic biliary procedure with stone removal. Iron overload. HCT candidates with diseases such as thalassemia, aplastic anemia, myelodysplastic syndrome, and chronic leukemia or lymphoma may come to HCT with marked hepatic iron overload. Moderate elevations in liver iron content, best assessed by T2-weighted MRI, have been inconsistently associated with increased non-relapse mortality post-HCT. 208 In patients with thalassemia major, effective pre-HCT chelation therapy improves post-HCT survival. In most other patients, however, the quantitation of tissue iron stores and consideration of iron removal can be deferred until after recovery from HCT. Problems from the time of the transplant through the first year: nausea, vomiting, and anorexia. Mucositis caused by high-dose conditioning therapy leads to oral mucosal swelling, pain, and, in severe cases, sloughing of pharyngeal and esophageal epithelium, intense gagging, an inability to swallow, vomiting, retrosternal pain, and airway obstruction. Some regimens, notably those that contain 5-fluorouracil, cytarabine, etoposide, high-dose melphalan, MEL, or multiple alkylating agents, may cause unusually severe intestinal mucosal necrosis and further delay the return of eating. Oral cryotherapy has been shown to decrease severity and duration of oral mucositis after 5-fluorouracil and high-dose MEL. 209 Myeloablative conditioning therapy makes most patients nauseated and anorexic, with delayed gastric emptying and poor oral intake, with the worst problems at day 10 to 12 post-transplant but often extending to day 20. 210,211 Serotonin 5-HT3 receptor antagonist drugs are very effective in relieving these acute symptoms during conditioning therapy, with the second generation 5-HT3 receptor antagonist palonostrine also helpful in treating delayed nausea and vomiting, day 2 to 5, .212 addition of dexamethasone N/or the neurokinin receptor antagonists such as aprepitant, netipitant, and rolapitant block the pathway where substance P initiates impulses to the vomiting center in the medulla and may prevent breakthrough nausea and vomiting. .213, 214 protracted anorexia may be related to circulating interleukin, IL-1, IL-6, and TNF-alpha, cytokines known to affect appetite centers. 211 Upper gut acute GVHD is the most common cause of these symptoms in allograft recipients. Early signs include loss of appetite, absence in pleasure from eating, and satiety, often followed by nausea and vomiting. When the onset of GVHD is before day 15 following a peripheral blood allograft, for example, the histologic features of GVHD may be indistinguishable from those Chapter 36 Gastrointestinal and Hepatic Complications of Solid Organ and Hematopoietic Cell Transplantation 519-36 resulting from conditioning therapy. After day 20, over 80% of allograft patients with intractable anorexia, nausea, or vomiting will have gastric and duodenal GVHD as the sole explanation. 215 Endoscopy shows edema of the gastric antral and duodenal mucosa, patchy erythema, and bilious gastric fluid, Fig 36.4. 216 Histology may show epithelial cell apoptosis and dropout, often with localized lymphocytic infiltrates. 216,217 The gamut of clinical presentation, endoscopic appearance, absence of infection, and histology needs to be integrated to arrive at a diagnosis when histology is equivocal. 216-218 Immunosuppressive therapy using a 10-day induction course of prednisone 1 mg/kg/day plus oral beclomethasone dipropionate 8 mg/day is an effective therapy for upper gut predominant GVHD that avoids prolonged prednisone exposure. 219,220 Recipients of autologous grafts may also develop a syndrome of anorexia, nausea, and vomiting that is associated with diffuse gastric edema and erythema. 221 Endoscopy also serves to rule out GI infection with herpes viruses, bacteria, and fungi as causes of upper gut symptoms. CMV infection of the esophagus, stomach, and upper intestine accounted for a third of patients with unexplained nausea and vomiting during the pre-Ganciclovir era, but CMV infection is now an uncommon cause of these symptoms. 215 CMV infections in the GI tract are usually diagnosed between 50 and 150 days after HCT, but can appear earlier if patients have CMV infection before HCT or receive cord blood transplants. 177,222 CMV infections can be detected in the GI tract in the absence of CMV antigen or DNA in peripheral blood. Nausea and vomiting may be prominent symptoms of some parasitic infections, if missed during pre-HCT screening, and infections caused by non-culturable viruses, norovirus, rotavirus, astrovirus. 182-184 Anorexia and vomiting may also be manifestations of increased intracranial pressure related to central nervous system infection, pseudotumor cerebri, or subdural hematomas. Oral non-absorbable antimicrobial drugs, particularly nistidine, cyclosporin, MMF, trimethoprim/sulfamethoxazole, voriconazole, posaconazole, itraconazole, amphotericin, and high-dose opioids also cause nausea and occasionally vomiting. Even after TPN has been stopped, appetite suppression may linger for 1 to 3 weeks. 223 Jaundice, hepatomegaly, and abnormal liver tests, Table 36.2 and Fig 36.5. Development of jaundice following HCT is an ominous prognostic sign, whether caused by drug toxicity, GVHD, infection, or hypoxia. 224,225 Recent advances, however, have made almost all liver complications of transplant preventable. 176,225,226 Sinusoidal obstruction syndrome SOS, see Fig 36.5a and b, is a syndrome of tender hepatomegaly, fluid retention with weight gain, and an elevated serum bilirubin concentration that follows some high-dose myeloablative conditioning regimens. 227 Because this form of liver injury is initiated by damage to hepatic sinusoids, the older term veno-occlusive ADBECF. Fig 36.4 Endoscopic and histopathologic manifestations of acute graft versus host disease, GVHD, of the GI tract. A. Esophagus, desquamation of squamous epithelium of the distal esophagus in severe GVHD. B. Stomach, diffuse mucosal edema and erythema in the gastric antrum in moderately severe GVHD. C. Small intestine, mucosal edema, focal bleeding, and ulceration in severe GVHD. D. Histopathology, focal apoptosis, ARO, caused by GVHD in crypt epithelium from a rectal biopsy. HNE, Alcyon blue. E. Histopathology, bottom of a colon crypt, AROs, is missing epithelial cells, apoptotic debris is admixed with mucus at the base of the crypt. HNE, Alcyon blue. F. Gross and histopathologic findings in fatal GVHD, autopsy photograph of a small intestinal segment opened to reveal sloughing of the mucosa, top. Histopathology shows complete absence of epithelial cells, lymphoid infiltrate, and submucosal edema, bottom. HND. 520 Part 4 Topics involving multiple organs. Table 36.2 Liver diseases after hematopoietic cell transplantation. Disease frequency, timing, diagnosis, treatment, prevention. Sinusoidal obstruction syndrome 10%, regimen dependent, onset before day plus 20. Typical clinical features, imaging, WHVPG, histology, see Fig 36.5a and b. Note atypical presentations, acute hepatitis, anasarca, none proved. Defibrotide successful in 40% of patients with severe SOS. Assess patient risk. Choose liver friendly conditioning regimen. Cholestasis of sepsis, cholangitis lenta, common in neutropenic patients, follows sepsis or neutropenic fever, usually before day plus 30, exclude other causes of cholestasis. Clinical diagnosis, treat underlying infection prophylaxis or expectant treatment. Ursodiol acute GVHD 20% of allograft recipients, rare after autograft day plus 15 to 50. Confirm GVHD in skin, gut, exclude other causes of cholestasis. Histology, see Fig 36.5 C and D. Glucocorticoids, 2 mg/kg/day. Ursodioxycholic acid. Optimal donor selection. Complete GVHD prophylaxis. T-cell depletion protocols. Ursodiol acute viral hepatitis, uncommon when prophylaxis is used against herpes viruses. Hepatitis B HSV, day plus 20 to 50. Adenovirus, day plus 30 to 80. VZV, day plus 80 to 250. HBV and HCV. During immune reconstitution, pre-transplant serology and PCR results, isolation of virus from other sites, stool and urine for adenovirus, PCR of serum for specific viruses. Liver histology/PCR/immunostains, see Fig 36.5 E and F. HSV, VZV, acyclovir adenovirus, cidofovir HBV, entecavir or tenofovir HCV. Consider direct-acting antiviral drugs if liver injury is severe HSV and VZV infection. Acyclovir prophylaxis for all patients if the patient is at risk for an HBV infection, lamivudine or entecavir. Choose an HBV immune donor. Fungal abscess, rare when prophylaxis is used. Day 10 to 60. Hepatic pain, fever. Liver imaging. Serum fungal antigen. Antifungal drugs. Pre-transplant screening. Oral antifungal prophylaxis for all patients. Drug-induced liver injury, common. Day 0 to 100. Clinical diagnosis, discontinue drug. Non-ischemic liver disease confined to patients with septic or hemorrhagic shock or respiratory failure. Day 0 to 50. Clinical diagnosis, restore cardiac output, blood oxygenation. Early treatment of sepsis, bleeding. Biliary obstruction, transient biliary sludges, common stones, chloromas. Rarely. Day 15 to 60. History, examination. Biliary US study, papillotomy plus or minus stent if obstruction persists. None. Idiopathic hyperammonemia, rare. Day 10 to 50. Venous blood ammonia, none proved. Unknown, probably genetic defect. Chronic hepatitis C, declining after day 80. HCV RNA in serum. Elevations of serum AST, ALT after immune reconstitution. Anti-HCV therapy after full immune reconstitution, www.hcvguidelines.org. Screen hematopoietic cell donors. Iron overload, very common pre-transplant. Long-term follow-up after transplant. MRI specific for iron quantitation. Transferrin saturation. Marrow iron quantitation. Liver iron quantitation may not be necessary. Phlebotomy, Chelation therapy if iron burden is very high, see text, avoid medicinal iron supplements. Chronic GVHD common after day 80 prior acute GVHD chronic GVHD in other organs characteristic alt, alkaline phosphatase levels histology, see Fig 36.5d, immunosuppressive drug therapy ursodeoxycholic acid screening for chronic GVHD at day 80 GVHD, graft versus host disease, SOS, sinusoidal obstruction syndrome, veno-occlusive disease, VZV, varicella-zoster virus, WHVPG, wedged hepatic venous pressure gradient. Chapter 36 Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation 521 36 Disease is inaccurate. The frequency and severity of SOS have fallen dramatically because 1. Doses of total body irradiation, TBI, above 14 Gray, GY, are seldom used. 2. Fludarabine is replacing cyclophosphamide, Cy. 3. Patients at risk for SOS are now given liver-friendly regimens that do not contain either Cy or that use TBI over 12 GY. 4. The prevalence of chronic hepatitis C in transplant candidates, formerly a common risk factor for SOS, is now very low, and 5. Therapeutic drug monitoring allows personalized dosing of chemotherapy drugs that have variable metabolism. 176 SOS is caused by toxins in certain conditioning regimens. Important contributors to variability in the incidence of SOS are 1. Variations in the metabolism of Cy from patient to patient in Cy/TBI regimens. 2. Underlying fibroinflammatory liver diseases. 3. The order of delivery of drugs in multi-drug conditioning regimens 203,228, and 4. Concomitant use of drugs during and after conditioning therapy that either affect the metabolism of myeloablative drugs, e.g., itraconazole, or that cause concomitant liver injury, e.g., methotrexate, sirolimus, norethisterone. Although fatal SOS has nearly disappeared from most adult transplant units, 175,229 pediatric patients receiving Bulletin/MEL conditioning regimens remain at risk. 230 Many past patients diagnosed as having SOS on the basis of jaundice probably had mostly cholestatic and not sinusoidal liver injury, a conclusion based on data from urosodiol prophylaxis studies. 175,226,231 The onset of SOS is heralded by an increase in liver size, right upper quadrant tenderness, renal sodium retention, and weight gain, occurring 10 to 20 days after the start of Cy and later after other myeloablative regimens. 176 Hyperbilirubinemia follows by 4 to 10 days. Concomitant renal and lung dysfunction and refractory thrombocytopenia strongly suggest SOS. 227,232 Elevations of serum AST/ALT weeks after the clinical onset of SOS reflect ischemic hepatocyte necrosis from sinusoidal fibrosis. 233 Doppler US is useful for demonstrating hepatomegaly, ascites, periportal edema, attenuated hepatic venous flow, and gallbladder wall edema consistent with SOS, as well as for excluding other causes of hepatomegaly and jaundice. Abnormal findings later in the course of SOS may include an enlarged portal vein diameter, slow or reversed flow in the portal vein or its segmental branches, high congestion index, portal vein thrombosis, and increased resistive index to hepatic artery flow. Shear-wave US elastography is an emerging technology that may help detect SOS earlier than traditional Doppler US in pediatric patients. 234 A transvenous approach that allows both liver biopsy and hepatic venous pressure measurements is the most accurate diagnostic test. AADBECF Fig 36.5 Histopathology of liver diseases following hematopoietic cell transplantation. A. Sinusoidal obstruction syndrome, also known as veno-occlusive disease of the liver, at 23 days post-transplant, high-power view of hemorrhage into the space of DIS, hepatocyte necrosis, disrupted sinusoids, and subendothelial edema of the central vein, arrow. The lumen of the vein is patent. H&E. B. Sinusoidal obstruction syndrome caused by gemtuzumab ozogamicin, high-power view of zone 3 of the acinus, showing extensive sinusoidal fibrosis, hepatocyte dropout, and a patent central vein. Masson trichrome. C. Acute graft versus host disease, GVHD, at day 82 post-transplant, portal area containing abnormal small bile ducts, arrows, with epithelial cell dropout, cytoplasmic eosinophilia, and vacuolization. HND. D. Chronic GVHD at day 184 post-transplant, high-power view of a portal area with damaged small bile ducts, arrows, infiltrated by lymphocytes. HND. E. Varicella-zoster virus hepatitis, low-power view of confluent necrosis of hepatocytes, arrows, pointing to pale area, adjacent to hepatocytes that are normal. Periodic acid Schiff. F. Adenovirus hepatitis, low-power view of a focal area of confluent hepatocyte necrosis, arrows, pointing to basophilic area, with remnants of hepatocytes that contain intranuclear inclusions typical of adenovirus, smudge cells, best seen at higher power. HND. 522 Part 4 Topics involving multiple organs. Hepatic venous pressure gradient above 10 mm Hg in this clinical setting is highly specific for SOS. 235 Initial histologic changes are dilation of sinusoids, extravasation of red cells through the space of Ds, necrosis of perivenular hepatocytes, and widening of the subendothelial zone in central veins. 236-237 The later stages of SOS are characterized by activation and proliferation of stellate cells, extensive collagenization of sinusoids, and a variable degree of obstruction of venula lumens, leading to obliteration of sinusoidal blood flow. 236-237 Intensity of collagenization of sinusoids and central veins and the degree of hepatocyte necrosis, as reflected in serum ALT levels, correlate with outcome. 233-237 Complete recovery from SOS occurs in over 70% of patients with just supportive care. Patients with severe SOS seldom die of liver failure, but rather from renal and cardiopulmonary failure. 227-232 Adverse prognostic findings include the rapidity with which weight is gained and serum bilirubin rises, serum ALT levels over 1500 U/L, development of ascites, renal insufficiency, and hypoxemia. 222-233-239 The key to prevention of SOS is understanding its pathogenesis. 237-239 Toxic damage to hepatic sinusoidal endothelial cells, not venula damage and not thrombosis within the liver vasculature, is the proximate cause of SOS. The most common causes of sinusoidal damage are regimens that contain Psi and regimens that use TBI, with the combination of Psi and TBI doses over 12 GY being the most common cause of fatal SOS. 232 Patients who generate a greater quantity of toxic Psi metabolites are more likely to develop fatal SOS. 228-240 A total Psi dose of 100 to 110 mg/kg, instead of 120 mg/kg, will lower the frequency of organ toxicity in the Psi/TBI regimen. 240 When combined with Psi 120 mg/kg, the total dose of TBI is related to the frequency of severe SOS approximately 1% after Psi/TBI 10 GY, 4% to 7% after Psi/TBI 12 to 14 GY, and 20% after Psi/TBI over 14 GY. Buletin is another component of regimens with a high frequency of SOS, but buletin itself does not appear to be hepatotoxic. 241 Buletin may contribute to liver injury by inducing oxidative stress, reducing glutathione levels in hepatocytes and sinusoidal endothelial cells, and altering Psi metabolism. 228 Giving Psi before 4 targeted buletin, particularly in patients with myelofibrosis 202 leads to less liver toxicity than with targeted buletin/Psi. 228 Mel pharmacokinetics, also widely variable from patient to patient, can be normalized using therapeutic drug monitoring. 242 The risk of SOS increases when high-dose gemtuzumab ozogamicin is given in proximity to myeloablative regimens that contain sinusoidal toxins. 204 Procollagen peptides appear in the serum of patients who develop more severe SOS, along with inhibitors of fibrolysis, consistent with the intense fibrosis in sinusoids and venula walls that is common in fatal SOS. Immunohistology for alpha-actin in liver specimens from patients with SOS shows intense staining in activated stellate cells, the source of collagen deposition into sinusoids. 237 Genetically determined differences in drug metabolism or susceptibility to toxic injury might explain some of the variability in the frequency of SOS, but there is no current method of altering drug dosing or determining susceptibility of individual patients to sinusoidal injury based on genomic data. 243 The only certain way to prevent fatal SOS is to avoid damaging hepatic sinusoidal endothelial cells, especially in patients at risk. Prevention of severe sinusoidal liver injury begins with an assessment of the risk in patients with underlying liver disease for a given myeloablative conditioning regimen. These strategies have had a striking effect on the frequency of SOS as a complication of HCT. 175,229 Patients at risk for fatal SOS have several options. 1. Conventional therapy of their underlying disease that does not involve HCT. 2. A reduced intensity conditioning regimen. 3. A myeloablative regimen that does not contain Psi, for example, targeted buletin fludarabine for allogeneic 243,244 or BEAM for autologous 245 HCT. 4. Modification of Psi-based regimens with either a change in the order, e.g., Psi/targeted BU228, or reduction in Psi dose to 100 to 110 mg/kg, and 5. Use of pharmacologic approaches to prevent sinusoidal liver injury. If a Psi/TBI regimen must be used for a patient at risk for fatal SOS, modifications should be considered for both Psi, 100 to 110 mg/kg, and TBI, less than or equal to 12 GY, dosing. If a buletin/Psi regimen must be used for a patient at risk for fatal SOS, liver toxicity is less frequent if Psi is given before targeted buletin or if dosing of Psi is delayed for 1 or 2 days after completion of buletin. The metabolism of 4-buletin is variable, with a several-fold range in the area under the curve, OSPU, a problem that can be addressed by therapeutic drug monitoring. 244,246 Use of therapeutic drug monitoring to normalize exposure to MEL is also feasible. 242 Another approach to decreasing the toxicity of regimens that contain buletin and MEL is to give them in reverse order, MEL/buletin. Pharmaceutic prevention of SOS has been achieved in animal models of sinusoidal injury but not in man, with the possible exception of difibrotide infusion, discussed later. 230 Prospective studies have shown no benefit from use of prophylactic heparin, antithrombin 3, or N-acetylcysteine in preventing fatal SOS. A meta-analysis suggests that ursodeol may prevent SOS 226, but SOS was not differentiated from cholestatic liver disease in these studies, and a large randomized trial showed no effect of ursodeol on the frequency of SOS but a large effect on the frequency of cholestatic jaundice. 231 For the more than 70% of patients with SOS who will recover spontaneously, treatment involves management of sodium and water balance, preservation of renal blood flow, and repeated paracentesis for ascites. That is associated with discomfort and/or pulmonary compromise. Patients with a poor prognosis can be recognized soon after disease onset by steep rises in total serum bilirubin and body weight, serum ALT values over 1500 U/L, portal pressures above 20 mm Hg, development of portal vein thrombosis, and especially by multi-organ failure requiring dialysis, hemofiltration, or mechanical ventilation. 227, 232, 233, 238 There are no satisfactory therapies for severe SOS. The best current results, 46% complete response rate, defined as total serum bilirubin less than 2 mg/dl and resolution of multi-organ failure, are with 4-difibrotide. 247, 248 Difibrotide is approved in the US and Europe for curative treatment of severe SOS, but the high treatment cost is a challenge for transplant centers. A cost-effectiveness analysis of defibrotide for treatment of severe SOS found the incremental cost-effectiveness ratio was $47,735 per quality-adjusted life years gained. 249 Transhepatic shunts have been placed in patients with SOS to reduce portal pressure and mobilize ascites, but neither serum bilirubin levels nor patient outcomes were improved. Patients with persistent ascites and normal serum bilirubin have undergone successful portosystemic shunts. Peritoneovenous shunts for intractable ascites have been unsuccessful. Successful ULTs for severe SOS have been reported. 250 However, in most centers, patients at risk for recurrent malignancy are low-priority candidates for a cadaveric liver. Prevention of sinusoidal injury has proved to be a more effective strategy for improving HCT outcomes than treatment of patients with severe sinusoidal damage. 175 Cholestatic disorders. Prophylactic ursodeoxycholic acid reduces the frequency of cholestasis in general and GVHD-related cholestasis specifically and improves outcomes, compared to placebo. 175,231 Now that the frequency of SOS has declined greatly, the leading cause of post-HCT jaundice is cholestatic liver injury. 176,225 Cholangitis lenta. Hyperbilirubinemia is common when patients are neutropenic and febrile and have gut mucosal injury from the conditioning regimen. Hepatocyte retention of conjugated bilirubin is mediated by endotoxins, IL-6, and TNF-alpha. 169 Although this disorder is often referred to as cholestasis of sepsis, it occurs in patients with fever alone and in the presence of localized infection in the lungs and soft tissues. See Chapter 37. Chapter 36 Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation. 523 36 Acute graft versus host disease. Acute GVHD, see Fig 36.5c, develops in up to 70% of allograft recipients. Prophylaxis with ursodeol has greatly decreased the frequency of jaundice after transplant and has altered the clinical phenotype of GVHD. 175,231 In retrospect, what had been called hepatic GVHD is a melange of three processes. The first process is jaundice occurring early in GVHD, where cholestasis is caused by cytokines such as IL-6.209,251. The second process is characterized by increases in serum bilirubin, alkaline phosphatase, and GGTP, usually in patients with GI GVHD in whom liver biopsies show lymphocytic infiltration of small bile ducts with nuclear pleomorphism, epithelial cell dropout, and cholestasis in zone 3 of the liver acinus. 251 Inflammatory infiltrates may be minimal because of immune suppression. Persistent hepatic GVHD and worsening jaundice are associated with ductopenia. The third process in hepatic GVHD is most commonly seen in allograft recipients on minimal immunosuppression or after donor lymphocyte infusion, in whom GVHD presents as an acute hepatitis with marked elevation of serum ALT. 252,253 Prognosis in patients with GVHD is not related to peak severity of signs and symptoms, but rather to the area under a disease activity curve, where persistent jaundice is an independent predictor of mortality. 254 Drug-induced liver injury. Cyclosporin inhibits canalicular bile transport and commonly causes mild increases in serum bilirubin concentrations without an effect on serum ALT or alkaline phosphatase levels. Tacrolimus causes cholestasis less commonly, except in the setting of toxic blood levels. Many other drugs used after HCT have been associated with liver dysfunction, e.g., trimethoprim/sulfamethoxazole, itraconazole, voriconazole, fluconazole, posaconazole, although drugs are usually not responsible for severe liver injury in this setting. 203,233 Acute hepatocellular injury. The incidence of severe hepatocellular injury after HCT has declined remarkably since the 1990s. 175,233 A sudden rise in serum aminotransferase enzymes, AST and ALT, following HCT is usually due to a non-infective cause, such as zone 3 hepatocyte necrosis in SOS, peaking around day 20, hypoxic liver injury, as in septic or cardiogenic shock or respiratory failure, acute biliary obstruction, cholecystolithiasis, DILI, or the acute hepatitic presentation of GVHD discussed earlier. 176 If a likely cause is not apparent, acute viral hepatitis should be suspected. Early diagnosis and treatment may prevent a fatal outcome. Acute hepatitis caused by HSV, VZV, adenovirus, and HBV can lead to fatal fulminant hepatic failure after HCT, whereas hepatic infections caused by CMV and HCV are seldom severe. See Fig 36.5e and F. With routine use of prophylactic acyclovir or valacyclovir, acute hepatitis due to HSV and VZV is now rare. However, HHV6 and HHV8 reactivation and HEV as causes of hepatitis have been reported after HCT.255,256 when there is uncertainty about the cause of rising serum ALT and AST levels. Serum PCR tests for herpes viruses, adenovirus, HCV, HBV, and, in some circumstances, HEV should be performed. Blood tests for viruses have largely replaced the need to obtain liver tissue for viral diagnosis, but transvenous measurement of the wedged hepatic venous pressure gradient with liver biopsy can be useful in diagnosis of unsuspected SOS or other causes of hepatocyte necrosis. If acyclovir is not being given, it should be started empirically, particularly if the patient presents with abdominal complaints typical of VZV infection. 257 Adenovirus hepatitis should be suspected if the patient has concomitant pulmonary, renal, bladder, or intestinal symptoms, but may present just with fevers, raised liver enzymes, and hypodense regions in the liver on abdominal CT, along with features of bone marrow suppression. 258 The most effective treatment is cidofovir when given early in the course of adenovirus infection, but many cases are fatal. 259,260 New agents are in development. Fulminant hepatitis B may develop during immune reconstitution in patients at risk, but can be prevented with prophylactic antiviral agents. 261 If severe hepatitis B reactivation does occur, usually because a diagnosis of HBV was not made prior to HCT, antiviral therapy with the most potent anti-HBV drug available, entecavir or tenofovir, should be initiated immediately. However, progression to fatal liver failure is not uncommon. 262 Fulminant hepatitis B has also been reported following discontinuation of prophylactic antiviral therapy, and all patients, particularly those with high pre-transplant HBV DNA levels, should be monitored following antiviral drug withdrawal. 263,264 Chronic hepatitis C in HCT recipients usually results in asymptomatic elevation of serum ALT from days 60 to 120, coinciding with the tapering of immunosuppressive drugs. 198 However, in recent years, treatment of chronic HCV infection in patients with hematologic malignancies with DAAs has become the standard of care. HCT recipients without contraindications to DAAs and who do not receive treatment prior to transplantation should be treated for HCV once the patient has ceased all immunosuppressive drugs and has no evidence of active GVHD. 198,265 DAAs might also offer an effective treatment in the rare case of severe hepatitis and fibrosing cholestatic hepatitis due to HCV after HCT. 197 Fungal and bacterial infections. Antifungal prophylaxis has significantly reduced the incidence of hepatic fungal disease in HCT recipients. 266 Presenting features include fever, tender hepatomegaly, and increased serum alkaline phosphatase levels. Resistant Candida species or molds should be suspected. 266 High-resolution CT or MRI may demonstrate multiple fungal abscesses, and serologic tests for fungal antigens may be useful for diagnosis. 190 Return of neutrophil function after HCT can affect resolution of a previously treatment-refractory Aspergillus infection. 267 Bacterial liver abscesses are rare in HCT recipients, probably because systemic antibiotics are so widely used. However, latent mycobacterial infection, including Bacillus calmette-guerin, may reactivate within the liver with prolonged immunosuppressive therapy. Disseminated clostridial infection and gallbladder infection with gas-producing organisms may lead to error in the liver and biliary system. Gallbladder and biliary disease. Biliary sludge, calcium bilirubinate and crystals of calcineurin inhibitors, is very common in HCT recipients. 268 Passage of sludge down the bile duct may cause epigastric pain, nausea, and abnormal serum liver enzymes. Biliary sludge may be a cause of acute acalculous cholecystitis, acute pancreatitis, and bacterial cholangitis. 269,270 Acute cholecystitis is uncommonly seen in HCT recipients and is usually not due to larger gallstones. 270 Cholecystitis in this setting may also be due to leukemic relapse with gallbladder involvement or infection by CMV, fungi, or rarely by other organisms such as Haemophilus influenza. Diagnosis of cholecystitis after HCT is difficult because of the high frequency of gallbladder abnormalities on US or CT in asymptomatic patients. Pericholecystic fluid, gallbladder wall necrosis, or localized tenderness suggest cholecystitis. Non-visualization of the gallbladder after a radionuclide bile excretion study with morphine infusion suggests cholecystitis. Biliary obstruction is a rare event caused by a variety of disorders, common bile duct calculi or inspissated biliary sludge, GVHD of the ampullary mucosa, lymphoblastic infiltration of the common bile duct, gallbladder, and ampulla of Fata in EBVLPD, CM-related biliary disease, dissecting duodenal hematoma complicating endoscopic biopsy, and leukemic relapse, scleroma, in the head of the pancreas. 270,271 In patients undergoing autologous HCT, biliary strictures are commonly due to recurrent malignancy. 272 The use of ursodeol to stimulate bile flow in patients with biliary sludge after HCT is ineffective. ERCP is indicated in patients with clinical evidence of cholangitis and radiologic evidence of biliary obstruction and allows for biliary stenting or dilation with acceptable risk. 271,272 524 Part 4 Topics involving multiple organs. Malignant hepatic disorders. EBVLPD is now an infrequent complication of HCT, largely because of EBV DNA surveillance and preemptive treatment with rituximab. The highest incidence was in recipients of HLA mismatched, T-cell depleted grafts and those receiving potent anti-T-cell therapies for GVHD. Symptoms include fever, sweats, generalized malaise, enlarged tonsils, and cervical lymphadenopathy, often with involvement of the liver and spleen, abnormal serum alkaline phosphatase and hepatosplenomegaly, and GI invasion. Malignancies that were the indication for transplant can appear in the liver as part of relapse. Idiopathic hyperammonemia and coma. A syndrome of hyperammonemia and coma has been described in patients who received high-dose chemotherapy, including conditioning for HCT. 273 Patients present with progressive lethargy, confusion, weakness, incoordination, vomiting, and hyperventilation with respiratory alkalosis. The diagnosis is confirmed when the plasma ammonia exceeds 200 mol/L and there is no evidence of liver failure. Rare cases associated with ureaplasma ureolyticum and ureaplasma parvum have been reported with subsequent improvements in ammonia levels and symptoms after treatment. 274 GI bleeding, Fig 36.6. Insignificant bleeding is very common, particularly when platelet counts are below 50 × 109/L. Causes include retching-induced trauma to the esophageal or gastric mucosa, mucosal injury from conditioning therapy, reflux esophagitis, C. difficile colitis, anal fissures, internal hemorrhoids, and acute GVHD. The incidence of severe GI bleeding after HCT is 1% to 2%. Lower than in the past because of effective prophylaxis against viruses, fungi, and acute GVHD. 275 Mortality from severe GI bleeding, however, remains at 40%. 275,276 The most common cause of severe bleeding is refractory acute GVHD, with bleeding from extensive ulceration in the small intestine and cecum. 277 Bleeding is an independent predictor of mortality in patients with severe gut GVHD. With ganciclovir prophylaxis and preemptive therapy, bleeding CMV ulcers have become rare. Gastric ulcerations may also be caused by infection by VZV, invasive bacteria, phlegmonous gastritis, or EBV, LPD, see Chapter 52. Although now rare after HCT, EBVLPD involves the GI tract in 20% to 25% of cases and can present as GI bleeding. GAVE can be a cause of severe upper intestinal bleeding in HCT recipients, particularly those who have received oral buletin. 278 Diffuse areas of hemorrhage are seen in the gastric antrum and occasionally small and large intestine, but the underlying mucosa is intact. 278-280 Histology is diagnostic, revealing abnormal dilated capillaries, thromboses, and fibromuscular hyperplasia in the lamina propria. Patients who are transplanted for advanced systemic sclerosis may bleed from similar vascular lesions. Endoscopic laser therapy or argon plasma coagulation are treatments of choice to control bleeding from vascular ectasia, but multiple treatments may be required to obliterate ectatic lesions. 278 Other rare causes of bleeding post-BDACE. Fig 36.6 Uncommon GI problems in hematopoietic cell transplant recipients. A. Esophagus. Barium contrast demonstration of an intramural hematoma that occupies one wall of the esophagus from the aortic arch to the lower esophagus. The red line approximates the normal esophageal contour. This hematoma was caused by retching in a thrombocytopenic patient. B. Stomach. Diffuse oozing of blood from the gastric antral mucosa in GAVE. When the blood was washed off, the underlying mucosa was seen not to be ulcerated, yet blood reappeared. C. Gastric histology. High-power view of an antral biopsy, illustrating the features of GAVE: capillary dilatation, thrombosis, and fibromuscular hyperplasia. H and E. D. Duodenum. Linear duodenal ulceration with yellow exudates, arrows, caused by rhizopus infection in a transplant patient receiving immunosuppressive therapy for graft versus host disease, GVHD. The surrounding mucosa is abnormal because of GVHD. E. Colon. Sigmoid colon in adenovirus colitis, showing diffuse mucosal edema, ulceration, and hemorrhage. Chapter 36 Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation. 525 36 HCT include ulcers caused by molds, Dieulafoy lesions, curling, stress, ulcers, duodenal biopsy sites, mycophenolate-induced enteritis, adenovirus enterocolitis, and C. septicum infection, typhlitis. Patients with severe amyloidosis who undergo autologous HCT may bleed from multiple ischemic ulcers throughout the intestine. 281 There is no effective therapy for mucosa that is diffusely oozing blood, other than platelet transfusions to raise the platelet count to greater than 50 × 109/L and treating the underlying condition, if possible. Continuous infusion of octreotide at 25 μg/Hr has resulted in cessation of bleeding from GVHD, but recurrent bleeding developed when the dose was decreased. 282 In GVHD, reepithelialization of ulcerated intestinal mucosa is very slow. Focal lesions, especially mucosal infections, can be treated with endoscopic cautery, heater probe, or epinephrine injection, provided platelet counts are adequate, but these therapies are futile in mucosa that is oozing blood diffusely. Unless the underlying disease process is eliminated, endoscopic methods will not cure the bleeding problem. Attempts to resect large segments of diffusely bleeding intestine involved with GVHD have not been successful. 277 Dysphagia, painful swallowing, and esophageal pain. Oral and hypopharyngeal mucositis from conditioning therapy, reflux esophagitis, and pill esophagitis are currently the leading causes of dysphagia and esophageal pain. Infections of the esophagus, fungal, viral, bacterial, have largely disappeared because of antimicrobial prophylaxis. When fungal esophagitis is discovered, the organism is likely to be a resistant candidal species or a mold. 283 Rarely, fungal esophagitis can lead to perforation. 284 Non-healing esophageal ulcerations, strictures, and dysphagia may uncommonly result from conditioning therapy. 285 In patients with gastric stasis related to acute GVHD, painful esophagitis is common, caused by reflux of both gastric acid and bilious fluid. In patients with severe acute GVHD, esophageal edema, erythema, and appealing epithelium lead to ulcerations. 286,287 Pill esophagitis occurs after ingestion of some medications in use after HCT, for example, phenytoin, foscarnet, captopril, oral bisphosphonates, ascorbic acid, ciprofloxacin, clindamycin, and oral potassium chloride. The abrupt onset of severe retrosternal pain, hematemesis, and painful swallowing suggests a hematoma in the wall of the esophagus, a result of retching when platelet counts are very low. See Chapter 45. 288 Endoscopy is relatively contraindicated because many intramural hematomas represent contained perforations. CT is the diagnostic test of choice. 289 The course of intramural hematomas is one of slow resolution over 1 or 2 weeks. Diarrhea conditioning therapy. Diarrhea caused by mucosal damage from high-dose conditioning therapy is seldom severe, usually resolving by day 12 to 15, with some exceptions. Cytarabine-containing regimens, high-dose mel, greater than or equal to 200 mg/m2, and regimens containing multiple alkylating agents may cause more severe and protracted diarrhea. 4. Infusion of octreotide and oral loperamide may be effective for severe diarrhea associated with conditioning therapy. 290 Graft versus host disease. Acute GVHD, Table 36.3, also see Fig 36.4, is the most common cause of diarrhea after day 15.291. However, GVHD may not be the sole cause of diarrhea in an individual patient, especially in patients receiving prolonged immune suppression, in whom reassessing the cause of diarrhea may detect infections not present at baseline. 292 GVHD may also be exacerbated by emerging off-label therapies, i.e., checkpoint inhibitors, for the treatment of relapsed hematologic malignancies after HCT. 293 The onset of GVHD diarrhea can be sudden, with stool volumes in excess of 2 L daily in severe cases. GVHD in patients who were grafted after reduced-intensity conditioning regimens may have its presentation delayed, occurring after day 100 in many patients. 294 The diarrheal fluid of GVHD is watery with ropey strands of mucoid material that reflect transmucosal protein loss. This presentation is almost diagnostic of intestinal GVHD, particularly when accompanied by decreasing serum albumin levels and negative stool studies for infection. 295 In atypical cases where GVHD is suspected, abdominal imaging may reveal intestinal edema and mucosal enhancement, particularly in the ileum and right colon, although the appearances of acute GVHD and CMV infection overlap. 296-299 Similar information can be obtained with PET. Pneumatosis intestinalis, which may be associated with GVHD or CMV enteritis, may be seen by plain X-ray, CT, or MRI, and in the absence of ancillary evidence of clinical severity, managed conservatively. 300 A definitive diagnosis of GVHD requires endoscopic views of mucosa, histology of GI mucosal tissue, and exclusion of infection. What the endoscopist sees should carry equal diagnostic weight to what the pathologist sees through the microscope. 216 Moderately severe GVHD causes diffusely edematous and erythematous mucosa throughout the GI tract. Severe GVHD may lead to ulcerations and large areas of mucosal sloughing in the stomach, small intestine, and colon. 301 Even when the appearance is normal, mucosal biopsies from the rectosigmoid or gastric antrum often reveal intestinal crypt necrosis and apoptotic bodies. Diagnostic of acute GVHD. 302 The diagnostic yield of mucosal biopsy is best when biopsies are obtained either from the distal colon and stomach or from the colon and ileum. 291, 301, 302 Visual inspection of the mucosa should be viewed as complementary to histologic findings. Other histologic findings that support the diagnosis of GVHD include pericapillary hemorrhage, infiltrating neutrophils or eosinophils, and evidence of endothelial damage. The use of capsule endoscopy for diagnosis of GVHD can provide visual inspection of the jejunum and ileum that cannot usually be seen with routine endoscopy. 303 The negative predictive value of a capsule endoscopy examination of the small intestine appears to be high and, therefore, is useful for excluding more severe acute GVHD. In severe cases of GVHD, whole crypts are destroyed, then adjacent crypts, and finally whole segments of intestinal mucosa. Bleeding often accompanies diarrhea in patients with mucosal ulceration. 275 Successful treatment of acute GVHD with immunosuppressive therapy results in a dramatic reduction in stool volume, with resolution of accompanying symptoms of abdominal pain, nausea, and vomiting. The management of patients whose diarrhea and other symptoms of intestinal GVHD do not respond after 5 days of immunosuppressive therapy is unsatisfactory because the rate of failure of secondary therapy is high. 304 Mortality in patients with high-volume diarrhea caused by GVHD can be predicted by a panel of clinical features within 14 days of onset: jaundice, age older than 18 years, lack of response to prednisone, and GI bleeding. 305 Other methods of predicting outcome in patients with GVHD include calculation of the acute GVHD activity index, measurement in decline of serum albumin level from baseline, and panels of serum biomarkers. 254, 295, 306, 307 Infection in allograft recipients. Infectious causes of diarrhea are far less common than GVHD, accounting for only 10% to 15% of diarrheal episodes. 276, 291, 308 Common bacterial pathogens are extremely rare after HCT 308 except in geographic areas where such infections are prevalent. 309 There are several infections that can closely mimic intestinal GVHD or, more commonly, coexist with GVHD, including non-culturable enteric viruses, astrovirus, norovirus, rotavirus, mycobacteria, fungi, and parasites. 283 C. Difficile colitis is usually a relatively mild, treatable disease. 526 Part 4 Topics involving multiple organs when diagnosed at the onset of diarrhea. 291, 310 Among HCT recipients with recurrent or refractory C. difficile colitis, fecal microbiota transplantation appears to be safe and effective with careful donor and recipient selection. 311 One often overlooked factor is the inappropriate use of PPIs for marginal indications, which increases the risk of C. difficile colitis twofold. 312 The most common cause of infectious diarrhea in a prospective study was astrovirus, a small, round virus similar to norovirus. Diagnosis can be made by PCR of stool specimens or by electron microscopy of small intestinal biopsies. 291, 313 Norovirus may also spread within hospitals as a nosocomial infection in HCT patients, with devastating consequences. 314 Some serotypes of adenovirus cause Table 36.3 Causes of diarrhea after hematopoietic cell transplantation. Cause, frequency, diagnosis, severity, treatment, myeloablative conditioning therapy. Common exclude infection. Hyperacute GVHD usually mild, can be severe after some regimens. Self-limited, octreotide useful in severe cases. Acute GVHD common after allografts, occurs in 10% of autografts. Association with skin and liver. GVHD, exclude infection. Abrupt decline in serum albumin is a marker of more severe GVHD. Mucosal histology in problematic cases ranges from mild to intractable high-volume diarrhea. Immunosuppressive drugs, usually prednisone. Initially viral infection. CMV now uncommon. CMV antigen or DNA in blood. Viral culture. Immunohistology of mucosal biopsy potentially fatal if not detected early. Ganciclovir or foscarnet adenovirus. Sporadic adenovirus DNA in blood or stool. Viral culture. Immunohistology of mucosal biopsy serotype dependent, may be rapidly fatal. Cidofovir norovirus uncommon, can be acquired by nosocomial spread in hospitals. PCR on stool specimen can be severe and protracted if immunodeficiency persists. None astrovirus uncommon. ELISA, PCR of stool. Self-limited. None rotavirus rare. ELISA, PCR of stool serotype dependent, can be severe. None EBV, lymphoproliferative disease, now rare. EBV DNA in blood, mucosal biopsy usually fatal when lymphoma. 2 Gut involvement develops. Rituximab when detected early. Withdrawal of immunosuppressive drugs. Bacterial infection. Clostridioides difficile common. PCR, toxin, and antigen in stool usually mild to moderate. Oral vancomycin. Phytoxamycin. Metronidazole. Clostridioides septicum. Sporadic clinical syndrome of typhlitis potentially fatal. Imipenem, oral vancomycin. Enteric pathogens rare except in endemic areas. Stool, blood culture potentially fatal based on organisms. Sensitivities: parasitic infection, Giardia lamblia, rare stool, ELISA can be protracted, metronidazole, Cryptosporidium hominis, rare stool microscopy, PCR, often protracted, recovery of immunity, Entamoeba histolytica, rare stool microscopy, antigen, PCR, serum EIA, potentially fatal, metronidazole or tinidazole, followed by paromomycin, strongyloides stercoralis, rare stool microscopy, potentially fatal, ivermectin, osmotic diarrhea, oral magnesium salts, common clinical diagnosis, dose dependent. Reduced dose, 4 mg++ carbohydrate malabsorption, common with gut GVHD. Infection, clinical diagnosis, diet dependent, disaccharide dietary restriction, antibiotic use, common clinical diagnosis, medication dependent, discontinue antibiotic medication, tacrolimus, unusual clinical diagnosis, dose dependent, reduced dose, loperamide, mycophenolate, mofetil, common clinical diagnosis, endoscopic findings, dose dependent, reduced dose, substitute enteric coated mycophenolic acid formulation, loperamide. Metoclopramide, unusual clinical diagnosis, medication dependent, discontinue EIA, enzyme immunoassay, ELISA, enzyme-linked immunosorbent assay, GVHD, graft versus host disease. Chapter 36: Gastrointestinal and Hepatic Complications of Solid Organ and Hematopoietic Cell Transplantation, 527-36 Necrotizing enteritis and rapidly fatal multi-organ failure involving the gut, liver, lungs, and kidneys. 283,315 There should be a sense of urgency in identifying adenovirus as a cause of enteritis. Delayed treatment is often ineffective. 316,317 However, not all patients in whom adenovirus is found in diarrheal stools have adenovirus enteritis. CMV is the only common infectious cause of enteritis after HCT that requires an intestinal biopsy for diagnosis. 291 As with adenovirus, CMV DNA can be detected in diarrheal stool specimens from patients who do not have demonstrable mucosal CMV disease. CMV can be found in mucosal biopsies in patients whose blood is negative for CMV antigen or DNA. 177,318 Otherwise, the predictive value of a negative stool examination for other viruses, bacteria, fungi, and parasites is high, particularly if molecular methods are used. 319 After HCT, watery diarrhea secondary to intestinal parasite infection, Cryptosporidium parvum, G. lamblia, E. histolytica, helminths, is rare, but sporadic cases are seen that can be confused with GVHD. 320-322. Strongyloides infection and hyperinfection syndrome have been described after HCT. Patients from endemic areas should be screened before HCT. 182 Non-tuberculous mycobacterial infection of the small intestine has been described post-HCT. 323,324 Other causes of diarrhea in addition to infection. Several other conditions may mimic GVHD, including brush border disaccharidase deficiency, bile salt malabsorption, pancreatic insufficiency, mucosal toxicity from MMF, and intestinal thrombotic microangiopathy. Intestinal inflammation often results in reduced expression of lactase and sucrase/isomaltase, leading to diarrhea if lactose or sucrose is ingested. Failure of bile salt absorption in the small intestine as a cause of diarrhea can be treated with colsavilum. 325 Pancreatitis and pancreatic insufficiency have been associated with calcineurin inhibitor therapy. 326 Transient pancreatic insufficiency has been described as a consequence of mucosal edema at the ampulla of Fata. 327 Japanese investigators have described intestinal thrombotic microangiopathy related to calcineurin inhibitors as a disorder that mimics GVHD. 328 MMF causes intestinal ulcerations and apoptotic crypt cells similar to the histology of acute GVHD. 329 Fewer GI side effects have been reported after conversion to enteric-coated mycophenolic acid in SOT recipients. 75 Diarrhea may also result from carbohydrate malabsorption, particularly in patients on antibiotics that affect the colon flora's ability to salvage carbohydrate. Oral magnesium salts, tacrolimus, a motilin agonist, and plerixafor, an immunostimulant. A cord colitis diarrheal syndrome has been reported in cord blood recipients. Pathology of endoscopic biopsies shows chronic active colitis with granulomas, and patients have responded to antibiotics. albeit with a high recurrence rate 0.330. However, other centers have not identified cord colitis as a cause of post-HCT diarrhea, which is caused by GVHD in most cases. 0.331 Abdominal pain. Abdominal pain may be an indicator of a rapidly progressive, fatal illness or an illness with a benign natural history that requires only conservative management. Table 36.4. The illnesses that may be rapidly fatal include intestinal perforation, some infections, e.g., typhlitis caused by C. septicum, adenovirus enteritis, visceral VZV infection, aspergillus vasculitis, gallbladder necrosis, and bacterial liver abscess. Fortunately, these disorders are far less common than intestinal pseudo-obstruction, narcotic bowel syndrome, acute GVHD, liver pain related to SOS, and hemorrhagic cystitis. Causes of severe pain to be sure, but not imminent death. The first question to answer is whether a patient with abdominal pain needs urgent surgery. Surgical intervention for abdominal pain after HCT is a rare event but is indicated for intestinal perforation, acute cholecystitis, drainage of abscesses, appendicitis, and in some patients with intestinal or biliary obstruction, typhlitis, and dissecting hematomas. 0.332 Surgical decision-making depends on the clinical situation, abdominal examination, and judicious use of imaging. Current imaging tests and careful examination should allow the surgeon to be highly selective in choosing candidates for operation, but clinical judgment may lead to surgical exploration or laparoscopy in problematic cases when one cannot exclude the possibility of a surgical disease, such as in pneumoperitoneum of unknown cause or possible gallbladder necrosis. Intestinal perforation may develop in the setting of therapy-induced necrosis of a transmural lymphoma or metastatic carcinoma shortly after conditioning therapy, or later from CMV ulcers or a diverticular perforation. Perforation may present with only mild to moderate abdominal pain and pneumoperitoneum on abdominal CT, especially in granulocytopenic patients. Pneumoperitoneum can be a manifestation of pneumatosis intestinalis, a much more benign process than free perforation, usually caused by CMV or GVHD. 0.333 Recognition of acute cholecystitis can be difficult because right upper quadrant pain, usually from SOS, and fever are common in the early post-HCT period, and imaging studies frequently show gallbladder wall thickening and luminal sludge in completely asymptomatic patients. A radionuclide study with morphine that shows filling of the gallbladder suggests that surgical cholecystitis is not present. However, false positive results, i.e., lack of gallbladder filling, can occur in severely ill patients on TPN. 0.334 When pain is localized to the right lower quadrant, typhlitis, C. septicum infection, and appendicitis are diagnoses that can be made by imaging, along with exclusion of other causes of right lower quadrant pain, renal, ovarian, abdominal wall. The most common cause of moderate to severe abdominal pain is intestinal pseudo-obstruction with bowel distension. The clinical findings of distension and tympany on percussion in the setting of opioid or anticholinergic drug exposure are virtually diagnostic. In visceral VZV infection, abdominal distension, severe pain, fever, and rising serum malt levels may precede cutaneous manifestations by up to 10 days, a presentation that occurs only among patients not receiving acyclovir prophylaxis. 257,335 Acyclovir should be started on clinical suspicion, while serum is analyzed by PCR for VZV DNA. Clinical pancreatitis is an uncommon cause of abdominal pain in HCT patients. Subclinical pancreatitis does occur, with symptoms masked by immunosuppressive drugs. 269 Patients with thrombocytopenia or prolongation of blood clotting may rarely bleed into the retroperitoneum, abdominal wall, or intra-abdominal viscera, particularly after duodenal biopsy, causing significant pain. The next question to answer is whether pain is caused by GVHD because there is an imperative to treat GVHD with glucocorticoids early in its course. Acute GI GVHD can present with just abdominal pain, but more commonly, a rash, nausea, vomiting, anorexia, or diarrhea accompany pain. The presentation can include a rigid abdomen with rebound tenderness, but more commonly crampy and periumbilical pain are present. With gastric mucosal edema, pain is localized to the epigastrium. The decision to treat a patient empirically when definitive evidence of GVHD is not at hand is difficult, but when the pretest probability of GVHD is high and that of perforation or infection low, oral prednisone, 2 mg/kg/day, should be started. CT or abdominal US, particularly with sonographic contrast, shows intestinal wall thickening in acute GVHD, a nonspecific but highly suggestive finding, particularly when CMV infection is unlikely. 297,299,336 delays in therapy may lead to more extensive mucosal necrosis and morbidity. 337 If the pain later proves to be due to causes other than GVHD, prednisone can be discontinued. The next consideration is whether pain is caused by a treatable infection. Recent advances in antiviral and antifungal prophylaxis have made intestinal and liver infections rare causes of abdominal pain. 175 Disseminated VZV with visceral involvement. 528 Part 4 Topics involving multiple organs may present with difficult to explain abdominal pain 2 to 6 months after HCT in patients not currently receiving acyclovir or ganciclovir therapy. Importantly, abdominal pain may precede typical VZV skin lesions by several days. 257 Patients should be started on 4-acyclovir while a definitive diagnosis is sought, VZV DNA in serum, gastric mucosal or liver biopsy. Other intestinal infections that may present with significant pain include adenovirus, CMV, cryptosporidiosis, infection with invasive molds such as Rhizopus species, C. difficile colitis, and C. septicum cystitis, typhlitis. Symptoms of typhlitis include fever, right lower quadrant pain, nausea and vomiting, diarrhea, occult blood in the stool, and shock. The diagnosis of typhlitis is usually made by imaging studies showing cecal edema. 338 Surgical resection for typhlitis is rarely necessary provided that antibiotic therapy, e.g., imipenem and oral vancomycin, for C. septicum is started along with systemic coverage for luminal bacteria and fungi in febrile patients. 339 In patients with intestinal pseudo-obstruction and gaseous distension, medical management is almost always effective and perforation rare. Although some infections of gut neurons, VZV and CMV, lead to pseudo-obstruction, mu-agonist opioid and anticholinergic medications are the usual causes, particularly in patients with gut inflammation. There are 3 approaches to opioid-related pseudo-obstruction: 1. Decreasing the opioid dose, 2. Peripheral mu-opioid receptor blockade with methylnaltrexone 153, or 3. Switching to a kappa opioid. Table 36.4 Causes of acute abdominal pain after hematopoietic cell transplantation. Cause, frequency, diagnosis, severity, treatment. Sinusoidal obstruction syndrome, SOS, now less common. Tender hepatomegaly, weight gain, jaundice. Potentially fatal. See text. Intestinal damage from conditioning therapy. Unusual examination, imaging can be protracted after some regimens. Non-colonic pseudo-obstruction common, particularly in patients taking mu-opioid or anticholinergic medications. May also occur with GVHD and VZV or CMV infection. Prior vincristine exposure increases risk. Distension, tympany, abdominal plain film when medication related, usually resolves. When a sign of GVHD or viral infection, may be severe. Reduce opioid, anticholinergic drug exposure, rule out treatable. Underlying causes, consider methylnaltrexone, neostigmine if persistent and severe. Hemorrhagic cystitis common after cyclophosphamide and with viral bladder infection. Suprapubic pain, hematuria, viral cultures, JC/BK virus or adenovirus, can be protracted with viral infection. Urologic therapy, antiviral drugs if appropriate. Acute GVHD common, particularly with more severe GVHD. Evaluate skin, gut symptoms, serum bilirubin. Intestinal imaging, CT, US, MRE, PET, mucosal biopsy. Potentially severe but not immediately fatal. Immunosuppressive drug therapy. Biliary pain. Unusual RUQ/epigastric localization, gallbladder sludge, gallbladder edema, gas, biliary dilatation. On US passage of sludge is usually self-limited. Necrotic gallbladder requires surgery. Persistent biliary obstruction requires stent placement. Surgery for gallbladder necrosis. Pancreatitis. Unusual serum lipase usually self-limited, but hemorrhagic pancreatitis occurs. Treat biliary. Infectious, and medication causes hematomas. Rare, can be seen after duodenal biopsy. Examination, abdominal imaging, endoscopy can be protracted. Restoration of platelet counts. Intestinal obstruction may require surgery. Intestinal infection. Unusual diagnostic and imaging tests for clostridial infection, VZV, CMV, adenovirus, norovirus, molds potentially fatal if not treated, especially Clostridium septicum, viral, or mold infection. Treat the organism. Discovered intestinal perforation, CMV ulcer, intestinal tumor necrosis, diverticula, now rare. Abdominal plain film, CT scan potentially fatal. Surgery. Liver abscess/bacterial infection rare, usually fungal. Liver imaging, MRI preferred. Examination, serum fungal antigen detection potentially fatal if not treated. Antifungal therapy, antibacterial therapy. Intestinal infarction, usually due to disseminated Aspergillus infection, rare. Intestinal imaging, examination, chest X-ray, galactomannan elisa. Uniformly fatal. Antifungal drugs. EBV lymphoproliferative disease rare with surveillance for EBV DNA in serum. Abdominal imaging, endoscopic biopsy usually fatal once tumor masses form. Rituximab when detected early, withdrawal of immunosuppressive drugs. EIA, enzyme immunoassay, GVHD, graft versus host disease, JC/BK, polyomaviruses, MRC, magnetic resonance cholangiography, MRE, magnetic resonance enterography, VZV, varicella-zoster virus. Chapter 36 Gastrointestinal and Hepatic Complications of Solid Organ and Hematopoietic Cell Transplantation. 529-36 Agonist, e.g., butorphanol. Anticholinergic medications are contraindicated in pseudo-obstruction, and drugs with anticholinergic side effects should be discontinued. Neostigmine, 2 mg 4, has been successfully used in patients with acute colonic pseudo-obstruction after HCT. 340 octreotide is useful for treating gut distension with fluid related to pseudo-obstruction. Perianal pain. Perianal pain after HCT can be caused by an anal fissure, a thrombosed external hemorrhoid, cellulitis related to tissue maceration, and infections. In patients with granulocytopenia, infections in the perineum or perianal spaces are usually polymicrobial, arising either from anal glands or from tears in the anal canal. Extensive supralevator and intersphincteric abscesses may be present without being apparent on external examination. 341 CT or MRI or endoscopy or transperineal US can give a clear view of the anatomy involved, particularly if there is pus present. 342 When antibiotics covering both anaerobic and aerobic bacteria are given to patients with cryptitis, incipient perianal infection, far fewer patients require surgical drainage than in the past. Unusual causes of perianal pain include giant condyloma acuminata, genital warts, caused by HPV, HSV infection, fungal infection, and CMV-induced cutaneous vasculopathy with perineal ulcers. 343,344 Problems in long-term transplant survivors. GI and hepatobiliary problems that occur in the years after allogeneic HCT are usually a continuation of symptoms of protracted acute GVHD, chronic GVHD, CGVHD, medication side effects, and infection related to immune suppression. 345,346 Esophageal symptoms. Heartburn may be worse if CGVHD is present because salivary gland destruction reduces bicarbonate production. Chronic GVHD may involve the esophagus, leading to dysmotility and failure to clear refluxed acid. 347 Protracted acute GVHD involving the stomach leads to gastric stasis and reflux of both acid and bile. Less common causes of esophagitis in survivors include fungal and viral infection and inflammation caused by retained pills, pill esophagitis. Common causes of dysphagia include esophageal and oral CGVHD, infection, xerostomia, and poor dentition. 345 Patients with extensive CGVHD often complain of dysphagia for solid food and pills. Children also present with insidious weight loss, retrosternal pain, and aspiration of gastric contents, leading to pulmonary disease that can be mistaken for GVHD-related bronchiolitis obliterans syndromes. The diagnosis of esophageal cGVHD is made by barium contrast X-ray or endoscopy, the latter of which should be done with caution because perforations have been reported. Radiologic findings include bullae, webs, concentric rings, narrowings, tapering strictures, and epiristalsis. 348 Characteristic endoscopic findings include desquamation of the upper esophagus and distinctive upper esophageal webs. Histologic findings include infiltration of the esophageal mucosa with lymphocytes, neutrophils, and eosinophils, necrosis of individual squamous cells in the basal layer, and desquamation of the superficial epithelium. Patients with esophageal cGVHD often need endoscopic dilation to avoid progressive luminal narrowing, but dilations must be done with extreme care because the perforation risk is higher than with peptic strictures. Topical glucocorticoid therapy can be effective. The risk of squamous cell carcinoma of the esophagus is 8.5-fold higher after HCT than among controls. cGVHD is the major risk factor. 349 Upper gut symptoms: anorexia, nausea, vomiting, satiety. Gastroduodenal GVHD in long-term survivors is called persistent, recurrent, or late acute GVHD because symptoms, endoscopic appearance, and histology are identical whether they occur before day 100 or years after transplant. 350 Long-term use of oral topical glucocorticoids can be effective in patients with protracted upper gut GVHD. 351 However, adrenal suppression and the symptoms of adrenal insufficiency, e.g., anorexia, nausea, from prolonged glucocorticoid exposure may mimic those of upper gut GVHD. Focal intestinal strictures can be seen as sequelae of gut GVHD. Herpes viruses, HSV, CMV, VZV, may cause nausea, vomiting, and satiety in survivors if prophylactic antiviral medications and viral surveillance have been discontinued. When upper gut symptoms appear along with abdominal distension and elevated serum malt levels, visceral VZV infection should be suspected and confirmed with PCR for VZV DNA in blood. 283,352 Gastroparesis may develop after HCT and typically responds to prokinetic agents. 353 Midgut and colonic symptoms: diarrhea and abdominal pain. Late acute GVHD or overlap disease with both acute and chronic GVHD can cause GI symptoms for many years after transplant. 354 Some patients who have had more severe GVHD in the past may develop intestinal strictures. 354,355 Sporadic cases of gut infection may occur with C. difficile, norovirus, CMV, and rarely G. lamblia and C. parvum, and may mimic GVHD. 283,320,321 Narcotic bowel syndrome may present with increasing abdominal pain and constipation in patients requiring opiates. 356 Bile acid malabsorption in the ileum may contribute to persistent low-volume diarrhea in patients receiving lenalidomide. Bile acid sequestering agents such as colsavelum may be helpful. 357 Rare cases of transmission of intestinal diseases such as celiac sprue via donor T cells have been reported. 358 Graft versus host disease of the liver. There are three presentations of liver GVHD in long-term survivors of HCT: 176,345,346. 1. Asymptomatic elevation of serum malt, alkaline phosphatase, and GGTP in the absence of jaundice. 2. Slowly progressive cholestatic jaundice with elevated serum alkaline phosphatase, a result of damage to small bile ducts. See Fig. 36.5d, and 3. Acute hepatocellular injury, hepatitic GVHD, with abrupt elevations of serum malt to over 500 U/L without preceding hepatic dysfunction. In long-term survivors, the differential diagnosis of jaundice is narrower than it is before day 100. The differential diagnosis of cholestatic jaundice includes GVHD, biliary obstruction, DILI, and fibrosing cholestatic hepatitis B or C. 176 If a cause of elevated liver enzymes is not apparent, a biopsy may be indicated to identify GVHD as a cause. The addition of urosodiol, 12 to 15 mg/kg/day, to the immunosuppressive regimen results in significant biochemical improvement in liver GVHD. 359,360 Severe hepatic GVHD can progress to ductopenia and deep jaundice, and may require a course of several months of therapy with prednisone, a calcineurin inhibitor, and urusodiol therapy to resolve. 251 Several case series, but no randomized trials, have touted the following as effective steroid-sparing treatments: Pulse Psi 361 extracorporeal, photopheresis 362 changing calcineurin inhibitors, or adding sirolimus. Oral beclomethasone dipropionate or budesonide could be used for hepatic GVHD, because 40% and 90% of these topical glucocorticoids, respectively, reach the portal circulation 363 and the liver. This approach to other inflammatory liver diseases, such as autoimmune hepatitis, has been effective. 364 Alt, including living donor transplantation from the original hematopoietic cell donor, has been performed in patients with refractory cholestasis. 530 Part 4 Topics involving multiple organs or end-stage liver disease due to GVHD. 250, 365, 366 Hepatitic GVHD can occur after discontinuation or tapering of immunosuppressive therapy, or after donor lymphocyte infusion. 252, 253 Patients who present with steeply rising serum malt levels, with or without jaundice, present a differential diagnosis of viral infection, DILI, and hepatitic GVHD. These patients require urgent diagnosis and treatment. Hepatic histologic findings include hepatocellular injury, lobular inflammation, lymphocytic infiltration in and around small bile ducts, extensive damage to, and loss of, small bile duct epithelial cells, cholestasis, portal fibrosis, and piecemeal necrosis. 252 Blood tests for viral antigen or viral DNA/RNA will exclude acute hepatitis due to a herpes virus, HSV or VZV, hepatitis viruses AE, or adenovirus. Acyclovir should be started pending results of tests for herpes viruses. If viral studies are negative, a calcineurin inhibitor and prednisone, 1 to 2 mg/kg/day, should be begun while histology is pending to prevent extensive ductal damage from GVHD. 252 Chronic viral hepatitis and cirrhosis in long-term HCT survivors with chronic hepatitis C. Cirrhosis develops with a median time of 10 to 18 years, compared to 40 years in controls. 367, 368 Confirmation of cirrhosis using either liver biopsy or non-invasive methods such as transient elastography. 369 is crucial so that patients can be monitored for complications, including esophageal varices and hepatocellular carcinoma. Chronic hepatitis C may also be a risk factor for development of lymphoma and other lymphoproliferative disorders after transplant. 370, 371 All survivors with chronic HCV, including those with cirrhosis, should be offered antiviral therapy unless contraindications exist. 198 Direct-acting antiviral drug combinations are highly effective and well tolerated. This website provides continuously updated recommendations for treatment of patients with HCV infection. www.hcvguidelines.org. Interferon-free treatment regimens are particularly attractive in post-HCT patients where the potential for interferon-induced activation of chronic GVHD is a concern. The serologic pattern of HBV infection may be atypical in HCT survivors because of immunosuppression. Clearance of surface antigenemia may be observed, and is particularly likely if the donor was anti-HBs positive from prior HBV infection or a robust response to vaccination. 192, 372 Patients who remain HBsAg positive after HCT are at risk of flares of hepatitis B activity, particularly at times of reduction of immunosuppression, such as during tapering or cessation of treatment for chronic GVHD. These patients should be taking antiviral agents such as tenofovir or entecavir for 12 months. After discontinuation of immunosuppressive treatment. 373 All long-term survivors with chronic hepatitis B should be regularly monitored to assess virologic and disease status and the need for antiviral therapy. 374, 375 Pegylated interferon cannot be recommended in allogeneic HCT survivors because of the concern for flares of cGVHD. HBV viral status should be reassessed prior to reintroduction of chemotherapy. 373 Biologic agents, such as rituximab used in the treatment of B-cell malignancies, have a particularly high risk of reactivation of occult hepatitis B, HBsAg negative and anti-HBC positive, and prophylactic antiviral therapy is recommended. 376 As in the peri-transplant period, patients with HBsAg should receive an antiviral agent whenever they receive immunosuppressive or cytotoxic therapy. Ascites. The most common causes of new ascites in HCT survivors are cirrhosis, e.g., accelerated development of cirrhosis in patients with chronic hepatitis C 367,368 and rarely in patients with hepatic GVHD, and, in non-cirrhotic patients, nodular regenerative hyperplasia of the liver, within the spectrum of idiopathic non-cirrhotic portal hypertension. 377 The diagnosis of nodular regenerative hyperplasia can be challenging because both liver imaging and wedged hepatic venous pressure measurements can be misleadingly normal. 378 The prognosis of nodular regenerative hyperplasia after HCT is generally good, although frequent large volume paracentesis or ATIPS may be required for management of complications. 379 Other causes of enigmatic ascites after HCT include constrictive pericarditis, pancreatic ascites, peritoneal carcinomatosis, and a serositis syndrome related to CGVHD. 380 Other liver disorders. Daily in patients receiving HCT is associated with antihypertensive drugs, lipid-lowering agents, hypoglycemic agents, NSAIDs, antidepressants, antibiotics, antifungal agents, or herbal preparations. 204 Although most daily responds to drug withdrawal, some drug reactions can result in chronic liver disease. Compared with the general population, patients develop new solid organ malignancies at twice the expected rate. 381 Because of the increased rate of chronic hepatitis C infection, the risk of hepatocellular carcinoma is particularly elevated. 381 Transplant survivors with risk factors for hepatocellular carcinoma, HCV cirrhosis, chronic HBV infection, or cirrhosis of any cause, should undergo surveillance every 6 months with liver US, according to international guidelines. 382 In one series of pediatric survivors of HCT undergoing liver MRI, incidental focal nodular hyperplasia lesions were present in 5.2%. 383 These lesions have characteristic central scars that differentiate them from hepatocellular carcinomas and fungal lesions. Because their appearance is so characteristic on MRI, 384 liver biopsy is often not necessary. However, when serum AFP levels are elevated in patients with apparent focal nodular hyperplasia, biopsy may be needed to exclude a hepatocellular carcinoma. 385 Liver infections caused by fungi and bacteria are now rare late complications. Non-sterile herbal remedies contaminated by molds may lead to liver abscesses in survivors. 386 Gallbladder and biliary diseases. Long-term HCT survivors have an increased incidence of gallstones and gallstone complications related to the formation of calcium bilirubinate microliths, biliary sludge, following myeloablative conditioning therapy. 268,387 Cyclosporin, and possibly tacrolimus, can predispose to cholesterol gallstones. 388,389 Biliary sludge and gallstones may cause cystic duct obstruction, bile duct obstruction, and acute pancreatitis. 270 Pancreatic disease. Acute pancreatitis is very uncommon in long-term HCT survivors, with most cases related either to biliary stone passage or, rarely, to tacrolimus-related pancreatic damage. 390 Pancreatic insufficiency caused by pancreatic atrophy, detected by CT or MRI, after HCT has been described. 391,392 Iron overload. Secondary iron overload is caused by both repeated transfusions and increased GI iron absorption in the setting of ineffective erythropoiesis. Morbidity from severe iron overload comes mostly from cardiac iron accumulation, which is only marginally correlated with liver iron content. 393 Iron-specific MRI methods can accurately measure not only liver iron but also iron accumulation in the heart, pituitary, pancreas, and thyroid. 394 The effects of persistent iron overload on long-term HCT outcomes have not been fully investigated except in patients transplanted for thalassemia, in whom very high iron burdens translate to increased mortality from cardiac causes. Iron overload could. Chapter 36 Gastrointestinal and hepatic complications of solid organ and hematopoietic cell transplantation 531-36 be a risk factor for morbidity and non-relapse mortality among HCT survivors with less extreme iron burdens than in thalassemia patients, although the best measure of iron status remains to be determined. 176,395 patients who died before day 100 after allogeneic HCT had levels of liver iron in the hemochromatosis range, 1,832 to 13,120 mg/g dry weight, 0.396.